Okay, we're on, Chair.
Okay, all right. Good afternoon, everybody, and welcome to the West Berkshire Health Scrutiny Committee. I'm Councillor Martha Vickers, Chairman of the committee. Members of the committee present this afternoon are Councillor Jane Langford, Billy Drummond, Owen Jeffrey, and Nigel Fulk will be joining us shortly. Councillor Alan McCrow is also present as Executive Portfolio Holder for Adult Social Care and Health Integration. Council officers and external partners joining us to advise and support the meeting are Fiona Warby, Lead Officer from Healthwatch, West Berkshire, Jodie Gordon, Emotion Health Academy Manager and Primary Mental Health Worker, Kate Pike, Senior Educational Psychologist, Acting Mental Health Health Lead and Manager of Mental Health Support Team, Neris Probert, Acting Senior Public Health Programme Officer, and John Ashton, Director of Public Health. Jodie, Kate, Neris and John hopefully will be joining us later. From Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board, we have Sarah Webster, Executive Place Director, Berkshire West, Helen Clark, Associate Director of Primary Care, Liz Stead, Head of Midwifery, Maternity, Neonatal and Women's Services, and Nikki Cartwright, Director of Vulnerable People's Services. Hopefully they will all be joining us later. Vicky Phoenix is the clerk for the meeting. The meeting is also being live streamed via YouTube and Gordon Oliver is the Zoom host. Before we start proceedings, I would like to explain for the benefit of members of the public who may be watching that this afternoon's meeting is being held both over Zoom and with councillors present in the council chamber. The meeting is being live streamed on YouTube, so members of the public are able to follow proceedings. Please can I ask everyone participating in the meeting to make sure they switch on their microphones when invited to speak directly into them, and to switch them off when finished speaking. If we hear the fire alarm this afternoon, we must leave the building immediately via the emergency exit. The assembly point is the Dolphin Car Park. If the lockdown alarm sounds, we will remain seated and await instructions from officers. We will adjourn the meeting until such time as it is safe to proceed. Do members have any questions about the way in which this meeting will be conducted before we proceed? No questions. Right, item 1, apologies. Do we have any apologies, Vicky?
We've received apologies from Councillor Justin Pemberton and Councillor Nick Carter. Councillors Owen Jeffrey and Billy Drummond are substituting.
Thank you very much. Item 2, the minutes of the meeting held on the 12th of September to be approved as a true and correct record of the meeting. Can I have a proposer, please?
So proposed.
Thank you, Councillor Jeffrey. And a seconder? I'm not quite sure. Thank you very much. Thank you, Billy. Right, I will now sign the minutes. Thank you. Item 3, members are asked to note the progress in relation to the actions. As regards action 15, Nikki Cartwright from Bob ICB has submitted a report and is here to answer questions. This is item 8 on the agenda. Action 17, Sarah Webster will present and answer questions on the winter plan today. This is item 9 on the agenda. Any further comments on the minutes from members? No, thank you. Item 4, do we have any declarations of interest relating to items on the agenda? No, thank you. Item 5, do we have any petitions in advance of the meeting?
No petitions have been received, Chairman.
Thank you, Vicky.
We don't have this lead.
We are waiting for Liz Steed to join us. She is on her way on Zoom. While we're waiting, can we move on to item 8? the report on continuing healthcare. We have Sarah Webster presenting this, or is Nikki Cartwright? Nikki Cartwright is here. Where is she? She's up there.
Yeah,
Oh, there she is. Thank you. Thank you, Nikki. So Nikki Cartwright, Director of Vulnerable People Services. She will give us a brief update and respond to members' questions. So this is the item on continual healthcare, which is page, where are we?
Page 31 on the additional.
Page 31 to 38 in your agendas. Thank you.
thank you very much. So at the last HOSC meeting, you asked me to come back with a high-level plan, which is what the first sort of 1 to 4 pages cover. So I think members may be aware that we had planned to complete our transformation programme with a restructure of our continuing healthcare teams. However, ICBs have been asked to look at their current structures and to look at our running costs. And so that means that our CHC restructure has now become part of that process. So that has slowed down some of the changes that we were hoping to implement. However, I think you can see from the project plan that what I've done is I've taken out the down the left-hand side, the different task and finish groups that we had identified through our transformation programme, and just outlined the plan, or the sort of the milestones that we have for those task and finish groups. So we're not stopping our transformation programme, but some of it is probably taking a slightly slower stream because we don't have some of the leads in place that we had hoped. I think, but I won't go into the detail unless you would like me to, Chair. It might be an idea for me to just stop here, take questions, and then talk about the second part of the report, if that's helpful.
Members, any members got any questions about this report, how it's presented? This is obviously going to take some time, isn't it? The transformation, Nikki.
Yes,
A lot of work to do.
yes.
So at the moment, we're not sort of showing much progress because it's sort of early days, isn't it? So.
Well, there's work in progress already, and that's what those slides should illustrate, the work that we've started already, and that sets out the sort of timescales for the completion of that, which I'm very happy to talk to, but I wondered if members would like to ask some questions.
Thanks, Chairman. Standard assessment conversion rate, Southeast region.
Oh, right, okay.
Please forgive me for not really understanding what that is. Could you just talk us through it, please?
Yes, so that, I need to open my copy. Just have to forgive me whilst I go back into I hadn't opened that part of the deck yet. Just
Madam Chairman, whilst documents and so on are being found, follow-on question is going to be very simple indeed, and I'm sure totally expected, and that is, why is it that Berkshire West has dropped from Q1 to Q2?
I've now been able to access the report. So I think when I was last here, you asked me to share information with you that compared us with the Southeast region or with a bigger footprint. So that's what this does. So it sets out Q1 and Q2 for our conversion rates, our independent reviews. I think it's also just in response to that question, the reason I can't give you an accurate reason why Berkshire West has dropped in terms of absolutes. However, it could be that the number of referrals coming through has reduced. It could be that more of the people who are being referred to us were the numbers were the same, but they're ineligible. So what we have commissioned is the Southeast region to undertake a review of our Berkshire West eligibility and our conversion rate, which will cover all 3 of the local authorities, and the DASs have been involved in signing off the scope of that work, and that will commence in January this year. And I think actually when I was last here, it was either here or Health and Wellbeing Board, I actually shared that information with you. So that will take place, and they will look at the previous quarter. So should I just explain now what the slides are telling us? Would that be helpful? Yes. So you'll see that Q1 and let's focus on Q2, it might be easier. So what we have here is we have the regional rate, which is the purple line, and the regional rate in Q2 was 17.2%. And then there's a national rate. So that's a national rate of standard assessment conversions into eligibility. The national rate was 20.5%. In Bob, you can see across the bottom there all the what we would call sublocations. So you can see Hampshire, both Sussexes. You can see Frimley, Kenton Medway, Surrey Heartlands, Brighton and Hove and Portsmouth. You can see that Portsmouth and Oxfordshire are above both the national rate and the regional rate, and you can see that Frimley is lower, and Surrey Heartlands, and then Berkshire West. Berkshire West is at 7% in terms of its conversion rate in Q2, and that compares with, as Councillor pointed out, 9.1% in Q1. In terms of our independent reviews, so this is when there is a dispute raised and somebody is not happy that they haven't been made eligible, or a local authority is not happy with the outcome of an assessment, then they can go to independent review. And again, you can see that in Q1 there were 53 cases heard. In Q4 there were 40. 6 in Q1 and 6 in Q2 were deemed to be fully eligible. 4 of them were deemed to be partially eligible, and it just gives you some narrative at the right-hand side of the slide to explain what that means. So it could be that the panel noticed that the patient had rapidly deteriorated, perhaps they were at the end of life, and so they probably would have become fast track at that point. And that's what can drive that. And then you'll see that out of the 53 cases that were heard at independent review in Q1, 37 of those were upheld. So those people that we had deemed as not eligible, those decisions were upheld, and 32 in Q2 out of the 40 were deemed to be not eligible. And then the last one is that 6 where there's no decision made in Q1 and 2 in Q2. And that again was just you asked me for that information at the last meeting.
Thank you for that. Yes, there's quite a few that proved to be not eligible, but obviously the report is saying your decision was judged to be correct. So, I mean, when people are judged not eligible, I assume they can come back and appeal. Do you think people are applying without enough information about eligibility, or is there just a great need for help out there and people just are trying to see whether they can get support, because a lot of time obviously must be spent in trying to assess people who are in the end not going to receive care. I mean, you know, the figures are just so worrying for Berkshire West that obviously we're sort of, you know, just quite concerned at the low rates.
So there's a process that's followed. So a checklist is something called a checklist is submitted. So that's done by professionals. That could be a social worker, it could be a district nurse, it could be you know, a range of professionals working in the local NHS or social care sector. That checklist then triggers whether the person should be assessed for continuing healthcare eligibility. So at that point, somebody could be deemed as, you know, there's already, we can see that their needs are not sufficient or insufficient to move them through the next stage. Then there is a full assessment that's taken place, and then health and social care colleagues come together. They work through the framework the national framework to agree on an outcome for that person as to whether they are eligible or not. I'm just wondering if, as a follow-up to this meeting, if it would be helpful if we shared that so that the committee members actually have sight of that. That might be helpful. At that point, an appeal can be made. It's usually done by local authority, but it can be done by relatives. And that would go into our local disputes process. And if the person's still not happy with the outcome of that process, then they can appeal to the South East Regional Team. So it's complicated, but most of that is done by professionals, not by carers or the individual, not by their relatives, unless they choose to do so.
So it's carers wanting the extra support, but they need properly assessed, and quite often it's not appropriate. I understand. Councillor Drummond?
Yeah, good afternoon. On page 33 on the Mental Capacity Act, could you tell me how the recruitment work's going along? And if you don't mind, give me a little bit of information in the development of the structure, because I'm new to this committee.
Is it possible for someone to share that on the screen? Page 33. I don't know. I'm not sure which part we'll...
It's the Mental Capacity Act.
Within the CHC team?
Yeah, I'm sure.
Okay, sorry. So when people are assessed for continuing healthcare, then it's important that we understand whether they have capacity or not. So that's part of the reason I was confused is because you said page 33 and mine only go to 1 to 4. That's what confused me. So apologies. Thank you, Vicky, for that. That's what we're looking at there. And it's really important that we have that capacity within our CHC team. It makes it a much slicker process. And at the moment, it's a sort of it's an add-on to people's roles. And what we want to do is to create some specific roles across the ICB who will make that will just be their day job, along with some other functions that they'll pick up. So the idea of our structure was that wherever possible, we would centralise functions so that, again, we would improve that resilience and we would build capacity. And we would have a bigger footprint on which to do that.
Okay, thank you.
Thank you. Councillor Foote?
Yeah, thank you very much. Could you just elaborate the criteria against which these assessments are made? Because, for example, I would imagine there's a national set of guidelines that the assessors refer to. And my question is, how does it work when the central government or, the Department of Health actually changes those guidelines? Because clearly then that will have quite a dramatic effect on who is eligible and that sort of thing. Could you sort of share with us what the workings of that are, please?
Yes, of course. So the national framework, I'll get the exact date and send that into Vicky. The national framework hasn't been updated for a couple of years now. It's and again, it might be helpful just to share what it is that the teams have to work through, because it is quite complicated. So you have to score across 4 domains, and you score sort of low, moderate, or high need, and that then drives out a score that means is somebody eligible or aren't they eligible. But I think it would be helpful if I shared that with you, or if I could just send that in with it as a set of slides, perhaps. Because I think that would give you greater oversight of it.
And Chair, if I may, if I could just follow up on that, what happens when there's a change, to those guidelines? And could you also share with us how frequently they change? You mentioned a couple of years ago, it was maybe the last change that has occurred, but clearly, I hesitate to use a very trite sort of phrase about moving the goalposts, but clearly, that has quite an impact on your teams, the assessment, and what the outcomes are. Thanks.
Again, it's best if I get you the exact date of when they were last updated, but that would have been done in consultation with local authorities and with, it would have been CCGs at that time, because any update to the statutory framework has an impact on key partners. But I will get that information for you, Councillor.
Thank you, everybody. Members, Nikki has offered to share more information about this, what is a complicated process, with us sort of outside of this meeting. So I think that would be, thank you for offering that. And I think that would be really, really useful. So sort of, obviously outside of the meeting, not as a part of the next meeting, we could have an informal Teams meeting where we could learn a little bit more and ask questions and have a little bit more time to really understand what's going on, because we're going to be hearing more about that as you come back and update us, and it would be really useful to really understand the process. So thank you very much for your presentation. Any more questions at this time, members? No, shaking their heads. So thank you very much for that, Nikki.
Thank you, Councillor.
And we look forward to more discussions. Thank you very much. Thank you.
Bye-bye.
Bye-bye. Thank you. Right, we now have Liz Stead on screen. While we were waiting, just had another item. Sorry, Liz. But we're all talking. Okay. Was that me? Is that okay? No, it's not okay. What's going on? Test. Something wrong. Liz, could you stop sharing? Oh, actually, it seems all right now. Okay, is that because? Okay, right. Okay, you still there? She's there, but we can't hear her. She's there, but we can't. Oh, right.
You'll ask her to go out and come back in again. And in the meanwhile, Sarah wants to do an item.
Okay. Can she? Well, we hope that Liz Stead can hear us. We're going to ask her. Oh, she's there. Okay. So shall I ask her to go out and come back again, or is that okay now?
We can't hear her.
We can't hear you, Liz. We can't hear you, Liz. Okay. So we're going to ask you to leave the meeting and come back again. And maybe we move on to Bob update.
Yeah, the winter plan.
We move on to the winter plan while you're doing that. Okay, so we have Sarah here to give us an overview of the winter plan. Thank you, Sarah. Thank you. And that is page 39 to 40, the winter plan. No, we don't have the paper. I beg your pardon. So can we hear?
Hi. Yeah, can you hear me?
So we can hear you. Thank you.
Excellent. And can you see the presentation on the screen?
Yes, we can. Thank you.
Excellent. We've got technology working. So hello, everybody. I'm Sarah Webster. I'm the Bob ICB Director for Berkshire West, which covers West Berkshire, Reading and Wokingham. And a large part of my role involves sort of convening all of the various partners in our system around kind of shared priority areas where we need to work together. And as part of that role, I'm the chair of our local urgent and emergency care board here for Berkshire West. So I will just take us through a couple of slides on kind of preparedness for this winter. We are very much in it at the moment, and then I'll allow time for any questions. I hope that's okay. So I won't talk through this word for word, and we'll share the slides afterwards. But just to reiterate, the sort of winter last year was a very challenging time for health and care services across the country. You'd have read it in the news. We've spoken about it here through this committee and through the Health and Wellbeing Board in the past as well. And so we are taking learning from last year, things that worked well, things where we continued to have to grapple with those challenges on a daily basis, and have been planning together as a partnership, starting early, thinking ahead to our the seasonal demand that we grow to expect over the winter period, and making sure that we are taking steps to be as prepared as we can be for this winter, to make sure that our services run smoothly and provide safe services for our residents. So before I go into some of that, I thought it was just helpful just to recap on what I mean when I talk about the urgent and emergency care system, because it's not just about ambulances and the emergency department. Actually, it's about a wide range of services provided by a wide range of organisations, starting in our own homes. So the actions that we can take as residents to protect ourselves for winter, and be ready in our own homes with preparing for repeat prescriptions, inhalers, and doing all we can to be on the front foot ahead of winter. Clearly, there's then community pharmacy, which is a really important point of contact for a number of issues, ailments and queries that we may have as residents. And then general practice in the community, including our out of hours general practice service, West Call. You've then got 111 services and a number of sort of the other services that don't fall within the acute hospital, such as our minor injuries services at West Berks Community Hospital, the Royal Berks Hospital, and at Townlands Memorial Hospital in Henley. Services for minor illnesses, and we're running an urgent care centre in Reading at the moment as a pilot for people with urgent but non-life threatening illnesses, who can go there 8 till 8, 7 days a week. We have an urgent community response team that if you see your GP and your GP is concerned, Berkshire Healthcare provide an urgent community response service that can come and see residents within a couple of hours, where applicable within the clinical criteria. And there's mental health crisis team support as well for residents who are suffering sort of a mental health crisis in that moment as well. Then we've got the services around sort of 999 ambulance services, the emergency department at the Royal Berkshire, which may lead on to a hospital stay, either within the Royal Berkshire or within one of our community hospital sites. And then the other part of the urgent emergency care system is around the support we can offer to our residents to return back to their home, or the place they consider home, which might be their own home, it might be a care home, and a number of those services, including social care and the really important role that social care plays in the urgent care system. So I hope that's just a quick helpful summary. When I talk about the system, there's such a wide range of services, partners, and differing offers to meet varying levels of urgent health need. So going into this winter, we've looked at the areas where we need to sort of reinforce, bolster, and make sure we've got surge plans in place for where we get surges in demand in different parts of our system. And so as part of this, we are looking to bolster some additional capacity within general practice, including making more appointments available both in our local practices and through our West Call out of hours general practice service. We're continuing to promote our urgent care service in Reading, which is a pilot that we're running at the moment in the Broad Street Mall that I mentioned a moment ago. We're continuing to review the use of our community hospital beds to make sure that patients can move to care as close to their home as soon as possible, as soon as they no longer need acute care, but may need a level of inpatient stay. We are enhancing what we call our virtual ward service, and this is basically where, with the aid of technology and health workers reaching out into somebody's home, they're able to return home sooner than otherwise they would have done in the past, where they might have stayed in the acute hospital at Royal Berks for a few more days. We've been very successfully rolling out this sort of technology-enabled approach over the last couple of years, and we're continuing to enhance that over this winter to make sure that people can be supported in their own homes where possible over this winter. We were given at the start of this financial year some additional national social care funding, some of which was obviously allocated through to West Berkshire, and I've been working with Paul Coe, your Director of Adult Social Services, to develop a plan for that additional funding, and across Berkshire West that is covering things such as helping to retain our social care workforce, securing additional care hours, and sort of bolstering brokerage arrangements. It is important to note that this is national funding that comes through the ICB, but into our Better Care funds, and an element also comes directly through the local authority into our shared fund, and the local authority element for West Berkshire was lower this year than it was last year because of a different national calculator applied, so we're just working with that context as well. But I thought it was important to note that for context. And then we're also really focusing on rolling out our COVID and flu vaccination programme to make sure we're protecting the most vulnerable residents this winter. It would be remiss of me not to mention the latest industrial action that's been announced over the depths of the winter period. So we've got 2 more junior doctor strikes on the horizon, one of which is happening next week from Wednesday the 20th of December. And then a second one is scheduled for Wednesday the 3rd of January, so immediately after the Christmas New Year period. We're working with all of our partners here in Berkshire West to make sure that we are as resilient as we can be as a system in the face of this industrial action, which I would say has been incredibly challenging for our providers and has resulted in consequences, both financial in terms of the level of funding that's being incurred to make sure our services are safe and covering shifts, and also the impact on our elective services in terms of having to cancel some planned appointments and planned surgery, which we try to avoid at all costs, but sometimes it's unfortunately proved inevitable. So that's been quite a large impact on our services, and we're continuing to face that over this winter period. But I want to just express my thanks to colleagues and partners from all organisations, including West Berkshire Council, for the role that you've been playing in helping to support the system and ultimately supporting our residents through this. So I think finally some take-home messages as part of our winter communications plan this winter. So I've already mentioned the flu and COVID vaccine programme, and we're really promoting that and want to encourage all residents who are eligible to please have your vaccine and help protect yourself for this winter. We've got our winter comms campaign that's going out through our various comms routes, and I believe our comms leads are linking in with equivalent comms leads in the local authority to make sure we're using all of our routes out to the public, with a big focus on sort of self-care and preparedness, as I've mentioned earlier. And knowing the correct routes to go to. So please only use the emergency department in an emergency. There are lots of other services out there that can support you if there's an urgent health need that's not an emergency. We've also listened to feedback that sometimes it's not always clear that sometimes when we go to our general practice, it's not always a GP that's the most appropriate clinician to see. And there's a whole range of clinicians that now work within our GP practices. And we've heard feedback that it's not always clear, and we've not always communicated this very well with our residents. So we've been working with Healthwatch, who are very helpfully doing a survey and getting feedback at the moment to help shape how we do this going forwards. But in advance of this winter, we've been working on some videos that we're trying to promote and share with some of our GP colleagues talking and wider clinician colleagues talking through the different roles that are available now in general practice. So you might see a nurse, you might see a physio, it might be a GP, depending on what your condition is, a whole range of different highly skilled clinicians that can see you within general practice. And then I've already mentioned the urgent care centre in Reading, which is something that is open 8 till 8, 7 days a week for urgent but non-life-threatening illnesses. It runs on an appointment basis, so you can turn up, and we encourage people that they can turn up and you'll be booked an appointment, which will be within a time frame that we can't guarantee in advance, but it means that you know when you're going to be seen. And we're running that pilot as well through at the moment. So that was my slide and overview, and I can share these slides and Vicky will kindly circulate them, but I will pause there for any questions.
Thank you. All right, we have a question from Councillor Langford.
Thank you, Chair. Thank you, Chair. The question is, thank you for that very interesting understanding. How is this information being got out to the general public?
So there's some national campaigns that go through nationally and national media. We are using our local social media platforms. We are working through sort of individuals promoting this, and our comms and engagement colleagues are working with, and if they're not, they will be working with colleagues in your own organisations to use the routes out that you have. It would be great if we can get some of these messages through into resident newsletters, or even through social media routes of you as individuals. So particularly thinking of councillors, you represent your constituencies and have routes into the people that I personally certainly don't. So that's been really helpful, and I think it's something we can always keep building on. And colleagues in Health Watch are doing a great job as well, helping to share these messages in the work that they're doing with communities.
Thank you very much. That was a very useful presentation. Thank you, Sarah. Yes, I mean, Jane asked about how you're getting information out. You mentioned a video to encourage people to use GP services appropriately, and that's probably showing in waiting rooms. Is that video being taken out to communities where people gather, particularly older people or any people, or, just sort of within community settings? Because surely that would be useful to get the message out.
Yes. So we're reviewing all routes to get this out into the community. So that's obviously a really, really helpful suggestion. I'll take that back to my comms and engagement colleagues to make sure that we are using every route possible.
Thank you very much. And you mentioned, how important it is not to misuse the urgency services, and we are aware about among all the other pressures. There are pressures on our ambulance services, and so people should be made aware that they must use services appropriately, but quite often they are just anxious. Councillor Foote.
Thanks very much, Chair. Can I ask, first of all, you mentioned that we get funding via the ICB from national social care funding, but the West Berkshire, I don't know if I heard this correctly, but the West Berkshire funding has decreased this year. Can you just elaborate on that? For example, is that a decision made by the council, or is that some sort of formula that is assessed nationally? Thanks.
Yeah, so last year, at quite short notice in the winter, there was some additional discharge funding announced. I think it was around November, December time. And it came through to us in two separate tranches, one through my organisation as the ICB, and a second tranche that went directly to every local authority in the country, with the view being that we should pool the two together and agree some integrated plans to support our residents home from hospital. In the current financial year, the ICB allocation remained largely the same as it was last year, and we allocated it out in the same way. So the ICB allocation to West Berkshire remained largely the same. The allocation that came directly through to local authorities they changed the calculation formula used slightly, which meant that the amount coming through to West Berkshire and also to Reading and Wokingham was slightly reduced on the previous year.
Thank you very much.
Thank you. Councillor Fudge has another question.
Yeah, sorry, I've got another question. I was interested with the if I can refer to this in this way, the non-doctor clinicians at GPs practices, you know, the practitioners, you mentioned physios, etc., who patients could access without having to go to the doctor in the practice. My question is, again, it follows on a little bit from Jane and Martha's points earlier. How do the general public, our residents in West Berkshire, how do they access those non-doctor clinicians at a GP's practice? Because I would imagine that can be quite challenging to actually get through to those people without maybe that individual having to physically go to the doctor's surgery, speak to a receptionist, and then get allocated an appointment. Can you elaborate on that, please, a bit? Thanks.
Yes, of course. So within each practice, there are routes to sort of triage depending on the need of the person who's calling for an appointment. So most practices have what we call a care coordinator, who will be the first point of contact for a resident when they're phoning the practice. The resident explains a bit about the condition and the reason why they're making contact, and they can then triage to the most appropriate clinical professional, whether that's a nurse or a doctor or a pharmacist or a paramedic, or the range of skills that they have within that given practice. So it shouldn't be any more challenging to see any of these clinicians than it would just be through picking up the phone, making an appointment, and within the practice they'll triage to the most appropriate individual.
I see. So you're saying that individual, the patient, would have to ring the practice. It would then go to the treatment coordinator, and they would then allocate that resident to whichever service they felt fit.
Yes, generally speaking, although a lot of our practices are also developing their sort of digital interface as well. So some of them you can send in a request on your phone on an app, and then they can work out what's the most appropriate appointment to allocate you to as well. So it's not always telephone, but telephone will always be there as an option, because we know that not everybody is able or wants to use sort of more digital technologies to book appointments.
Thank you.
Any further questions, members? No, we're fine. Well, thank you very much for that. I would just add that you're probably aware that we have a cost of living group at the council now. I think they're changing the name to sort of concern for poverty, but obviously any information about services which people struggling with the cost of living, obviously heating and eating, particularly heating, we're talking about the winter. Hopefully will be some liaison so we can be sharing information with practitioners who are seeing people in their homes, seeing them when they're being discharged. So we make sure that people stay well and don't need emergency care services. So hopefully will be some liaison. So thank you very much for your presentation. Thank you.
Thank you.
We'll now be moving on to maternity care with Liz Stead and Neris Probert. But before I do that, just to inform our two presenters for the Emotional Health Academy from the council who've come down, we've had a problem starting, so we shuffle the agenda around. So we're just a little concerned about your time constraint. On the agenda next is maternity care. Are you all right to sort of hang on and do your presentation? Are you all right? We'll probably be about roughly an hour. We might be, you know, at least half an hour, probably longer than that. So if you're okay with that, you're okay with that. Thank you. Thank you very much. Thank you very much. We've had a few problems. Okay. Well, we'll now move on to, we have a hand up. Is that Neris? Can't hear you.
Hi, yes. Just to say, I was asked to come to this meeting at short notice, and I do have to leave at 2:30, unfortunately. So I don't have a presentation, but I would be more than happy to come along to the next one and do a full presentation on the health visiting service and bring the health visiting service manager with me, if that would be more helpful.
That's fine, Neris. I don't think we were asking for expecting a presentation from you. I
Okay.
think it's Liz that has the presentation, which is in our pack.
Okay.
But we're here to respond to questions, particularly about health visits.
Sure.
We know we'll be seeing you some other time as well.
Okay, great. Thank you.
Very much. So we'll move over to Liz to talk to her presentation. Thank you.
Thanks. Can I just check that you can hear me okay?
That's fine. Thank you.
Excellent. That's brilliant. Thank you so much. And thanks for your patience, Chair and members and colleagues on the call. So I've been asked to come to talk to you today around maternal mental health, and I believe the presentation was shared in the pack, but I'll just go through it and obviously pick up any questions that any colleagues have at the end of the presentation. But really, I think more than anything, what I wanted to do was give an overview of how easy it could be to overlook the principles of women experiencing mental health around the time of their pregnancy. So we call this the perinatal period. That means during pregnancy and up to 1 year after the birth of the baby. And essentially, I think, you know, we're really clear now when we're talking about mental health that, you know, everybody has mental health and there's a spectrum of needs. And I think it's appropriate to, you know, to have a really clear understanding of exactly what it is we mean when we talk about mental health. So we could be looking at, you know, the kind of very normal ups and downs of people's emotions during the course of their life as they live their life, etc., right through to, you know, people that are very, very sick and need quite intensive intervention to keep themselves and other people safe. So I think really it's just to kind of set a bit of a scene for that. So, you know, obviously we always consider, or for the most part, consider that having a baby is a good thing and it's a blessing. But I do think that, you know, we can be really sometimes a bit overlooking of the fact that this, you know, significant life-changing experience, you know, doesn't always necessarily bring positive, only good things. Sometimes it can be quite triggering for women, and it can bring on experiences that are not particularly pleasant, some of which can resolve very quickly or are circumstantial or can be exacerbated by poor sleep or support issues or what have you. But for some women, they, you know, these conditions can continue on beyond the perinatal period. So the Royal College of Obs and Gynae estimate that 1 in 5 women experience mental health problems during pregnancy or will after the birth of the baby. And some women will embark on pregnancy with pre-existing mental health issues, which I'll go into a bit more detail about later. I think what we do need to be clear about is that packages of care can't be you know, very rigidly defined. And I think we have to move away from services that, you know, that we have to make the service user fit as opposed to the services fitting around the service user, if that makes sense to you. So our services are generally offered on the level of need, but I thought it quite important to include as part of the presentation this data around Embrace. Now, Embrace is it's a perinatal quality surveillance measure that we look at, and the latest report, which was published about sort of 6 weeks ago, I believe it was, looks at data in the period 2019 to 2021. And the reason I've included this is because of the 241 women who died, and it is it's a small number, admittedly, but it is a significant. 25 women died where mental health was found to be the primary cause. For us in Bob, that was 1 death relating to mental health, and just for members to be aware, that wasn't a lady from the West Berkshire area. It was actually a lady from the Buckinghamshire area. But just to give you the context around what that about what that actually looks like, and obviously, you know, in a relatively rich, developed country, you know, the thought that we have women that still die in childbirth is quite shocking. But I think obviously the issue around mental health is one of those areas that we think, you know, is this something that we could change, something we could improve? So in terms of the stages of pregnancy, if we think about preconception, you know, some women don't necessarily plan to become pregnant, but some women do. And obviously with women with pre-existing mental health conditions, What we know is that they may already have quite a robust package of care that's in place to support them on whatever level of need that they have. So, for example, women who've been managed within primary care and are stable and compliant with medication regimes, etc., can continue to be cared for by their GP. And conversations about medication will take place with with the GP and the woman, to make sure that everybody's aware of any potential risks, or where benefits outweigh risk, and the conversation about that, so that every decision around mental health is made with informed consent with the woman, and obviously if her family are part of that conversation as well. We always make it really clear that the GP should continue to monitor the woman over the course of the preconception and conception period, and liaise with the community midwife as needed. And in fact, actually, seeing Neris on the screen there reminded me that actually our health visiting colleagues are very much a part of this as well. So contact between community midwifery, GPs and health visiting, particularly where women are at a greater risk for whatever reason that is, in this case obviously mental health, those conversations should take place during the antenatal period, so that's before the baby's born, as much as possible. Women should be advised the pros and cons around that medication, as I said, giving really clear guidance. This is what this medication might or might not do. This is the benefit. Let's have a discussion about it. And, the conversation around offering alternatives such as talking therapies, other forms of therapy, referring into services, for example, for CBT, if that is necessary in preconception stages. It is really, really important. And I think, anyone that's in healthcare will make it absolutely clear at all points that a woman, even if she is pregnant, should never just stop taking medication for a mental health condition. It should always be done in full collaboration with her multidisciplinary team. So if it's with the GP, as per a discussion with the GP and a planning strategy put in place, and if it's more specialist service, very much part of the MDT. And women previously treated within community mental health teams or have been discharged within the last 6 months, again, should ensure that the woman is referred or signposted to the most appropriate level of care. And again, all of those options are open and available to all women and all colleagues. So when mental health starts in pregnancy or following the birth of the baby, we have to be really clear that this is a very kind of dynamic situation. You'll find that women that experience the beginning of deteriorating mental health during the pregnancy are not necessarily going to have every single day is dark, is gloomy, makes them feel very unhappy, etc. Very often it's a much longer period of time, and there will be good days and bad days interspersed with that. So midwives routinely ask questions of women at the booking appointment, and I'll put those in the slide here. These are called the Hooley questions, and we've been asking these questions of women as part of the booking process now for a very long time, probably at least 15 years, I would say, if not longer. And those two questions, very, very general questions, and actually not even just for pregnant women. It's a good starter for 10 in terms of the conversation for anybody experiencing mental health. So they're a good place to start. They are just those screening questions. So we've got to be really careful that we don't pin everything onto just two very broad questions, which obviously might lead us down a particular route. So this is where I think, we get very clear that our colleagues, our health colleagues are able to use their clinical skill, use their judgment, ask some of those softer questions around mental health, how women are feeling, etc., because it would be very easy to just take a no on both of those and not interpret any issues around mental health. So we should always look at the full picture. We should never just take two questions in isolation. always really important to consider medical history, particularly including mental health. And that's why it's quite important for, you know, midwives and the multidisciplinary team, including our health visiting colleagues, to have access to the appropriate records on the woman's health from prior to the pregnancy. We have to consider as well additional risk factors such as social circumstances, financial pressures, or domestic abuse. Now, we're not saying here that every time there's mental health, there's immediately, you know, safeguarding concern or that there must be something else going on, but we can't confine it to a box. We have to be really clear that we're keeping an open mind and keeping a broad spectrum on exactly what it is we're looking at. Also, how the woman feels about being pregnant. You know, I started this presentation by saying what a wonderful time it is, what a blessing it is. And, you know, for some women it isn't, and that's the truth of it. So I think, you know, again, digging a little bit deeper about what that looks and feels like for each individual woman, and also her ability to access services. So we know, for example, and Embrace certainly told us in terms of our women from ethnic minority communities, those that speak little English, or women that have learning disabilities or other complexities, that actually they are at a greater risk of, you know, poorer outcomes in pregnancy. So we have to be really clear that, you know, there is no one size on this. We have to tailor it to each individual woman. So deterioration during the perinatal period, you know, we're talking about the sort of, you know, more significant end here. When women become acutely unwell with mental health in pregnancy and occasionally after the baby's born, and that often requires intensive professional input and in some cases inpatient provision. For example, if the woman is at risk of becoming very unwell during the pregnancy or up to 1 year after birth, and very unwell would be, you know, that she's a risk to herself or to the baby or to other people. If she's got a history of psychotic illness such as bipolar disorder or schizophrenia, if the woman experiences sudden onset of depression or anxiety after the birth and is a risk to herself or others, which is a term known as puerperal psychosis, or you might hear it called postpartum psychosis, which is a severe mental illness and requires immediate, you know, and quite intensive input from services on that. So that's something that midwives and health visitors together and our colleagues in primary care would also look to support around that. If the woman had a traumatic birth, including cesarean section, for example, or any kind of birth that was particularly traumatic, and particularly where there were feelings of perhaps being out of control or not being able to make choices because things were happening very quickly, or if they feel distressed about becoming pregnant again because of a previous experience that they'd had, or struggling to come to terms with the birth experience and showing signs of PTSD, which can happen in some cases. So our perinatal mental health service for Berkshire West is provided by Berkshire Healthcare Foundation Trust, and they've got a good service around perinatal provision, which includes trauma services. And we know that some areas nationally don't have those robust processes set up and working at this time. There is a big push around that through the NHSE's work around perinatal mental health services to try and get some levelling up. But I think certainly for Berkshire West patients, the service is good. It's specialised, it's tailored to the women, and you know, really can be sort of managed around what the woman needs. It can involve the pre-birth planning, and that's multi-agency, multidisciplinary where necessary. So our social care colleagues, for example, if we need to think about, for example, any potential risks there might be to the baby or to other children in the family, or if there are any support issues around potential safeguarding, then they're really well placed to be able to have those conversations, as well as our midwifery and health visiting colleagues where necessary. Excuse me. CBT and other forms of behavioural therapy, with experts in perinatal care. So these are colleagues who have those additional skills, that additional knowledge and clinical expertise, to be able to recognise and work out with the woman and as I say, her family and other caregivers around what she needs. Any alterations to medication with supervision, and obviously that includes making sure that any recommendations regarding medication regimes are being complied with. Bearing in mind, if we're talking significant mental health likely to lead to harm, then it's really important that we're confident about those medication regimes. So the service is really good at being able to monitor those. Self-care and recognition of deterioration. So I think mental health colleagues, I'm not a mental health colleague by background, but colleagues that I know that work in mental health would say that actually, patients that have a good understanding of their condition and know, when they're starting to deteriorate and things are starting to, go downhill for them is actually a really important point. And being part of decision making if a woman requires inpatient help. So in the South East, we have 2 mother and baby units. We've got one in Winchester and one in Kent. Winchester is our most local, obviously geographically. It would also be our default unit to send any of our women to that did need inpatient provision. I think it's important to note that 2 units for the whole of the South East is not very many. I mean, you don't need me to tell you that that's probably very oversubscribed most of the time, and that is actually the case. So, but at the moment, that is the provision that we have. These slides actually I took out of the original, so I'm so sorry about that. These next 2 slides they actually came out of the original because the data sets are owned by Berkshire Healthcare. So apologies for those colleagues, but we can get data if you would like it from the provider. So birth trauma pathway, psychologists and CBT providers around the issue to do with post-traumatic stress disorder due to experiencing a difficult or traumatic childbirth. Now, this goes back to what I was referring to earlier around trauma. We've moved away, thankfully, from making the assumption, that childbirth's painful. It's not a particularly pleasant experience. Women just have to kind of, get on with it, really. We've moved away from that, and I think particularly now we're in an era where our expectation is live birth, live baby, live mother. Intervention in that birth process is inevitable, and I think as a result of that, sometimes those interventions can themselves cause trauma, even though they've been done for absolutely the right reasons. So it's really important that women are referred in if they are experiencing that trauma. I've put a few bullet points in there around the criteria about referral into the trauma service. But it's important to note that the trauma pathway is not instead of ongoing existing support and treatment services that are provided, either by the acute service or any other service that's been working with that woman. So it's really important to know this isn't an instead of, this is, if necessary, as well as, and part of that preempting process around support. So treatment options on that includes guidance on using mental health medication, as we've talked about previously, and also including in the postnatal period in respect to breastfeeding, because we know a lot of women are very anxious about the impact that medication might have on their ability to breastfeed and whether or not it crosses over through breast milk, etc. Care planning advice for women who are pregnant and have complex mental health needs, boosting wellbeing postnatally and to prevent relapse, and advice and support on mother-infant relationships. So you can see from that, this is a much more kind of preemptive, proactive approach around managing what might happen after that, after the birth of the next baby, when they've been referred through the trauma pathway. This is just a little bit about, it's a buzzword in health, or buzz phrase in health, I should say, but it really is more than that. It's really important, actually. Making every contact count, absolutely crucial that every single health professional that has contact with a pregnant woman or a woman who's just had a baby regardless of whether or not she's had mental health previously, or she's previously expressed issues around mental health or concerns about it. It's really important that every single health professional takes every opportunity to start a conversation, basically. And I think we're getting better at having those softer, less jagged conversations and very closed questions around, how's your mood? Are you okay? Yes, I'm fine. Much softer and much more inquiring about how we have those conversations. There's a nod there to the Sharon online network, which provides support around maternal wellbeing during pregnancy and in the 5 years following birth, and it provides a secure way for people across Berkshire to interact. Access to this is peer support is safe and it's available 24/7, and you get referred to that via a healthcare professional. And really, just to sum it up, I think it's fair to say that actually, as always in health and social care and most public services, frustratingly, it can be very difficult to work out which is the most appropriate service. And there are varying levels who figures that out. And we have to remember that whilst in health and social care services, we're having conversations about what fits where, etc. There is a patient, in this case a mother or mum to be, a baby, possibly a partner, a family, etc. around them, also navigating that with a level of concern, obviously, that we can't possibly understand because it's their loved one. So we need to make sure that we get it right and having those conversations. BHFT have got a gateway system that is available to all healthcare professionals to talk about the most referral route into the most appropriate service. So again, I guess key message is, don't assume that just because you've never had mental health before, that that it won't happen. And when we do recognise that a woman needs help and support, we recognise that quickly, and we get referral help and support through the most appropriate pathway as quickly as possible. Thank you.
Thank you very much, Liz, for that very comprehensive overview of the service. Well, possibly, we're all aware of the problems with maternal mental health across the country, and we have some pretty sort of astonishing statistics about not just suicide and deaths, which shouldn't be happening at all now, but the way women are suffering and not getting the care that they need. We're not sure from your report what the particular issues are locally. It's sort of basically telling us what the service is, but we can't see what the issues are, whether we have drastic issues as regards staffing. I'm sure we probably do. One of the things that, and you do mention in your report, is obviously the importance of identifying vulnerable women, the ones that are going to need extra support. And I know that and collaboration of health professionals. And in the past, we did have the GP, midwife, health visitor co-located in the doctor's surgery. This is some time ago. So actually this cooperation between the health professionals must be much more difficult now. So how are you possibly addressing that?
Yeah, thank you, Chair. I think you're absolutely right. The sort of I'll say glory days, that's probably the wrong thing to say, but when health visitors, midwives and GPs all kind of operated from the same physical base, it was very, very easy to be able to have those collegiate conversations with any of those colleagues that you'd be in the same building with on any day-to-day basis. I think it's fair to say that the issues that primary care have experienced in respect of estates over the last few years, which have led to the huge expanse of colleagues that now need to have primary care space, and as midwifery teams need to move to other locations such as children's centres and clinics, etc. It has caused a hiccup, I think it's fair to say, in that level of communication. But I think for West Berkshire actually, and actually for services that are covered by Berkshire Healthcare, actually, I think the acknowledgement of that and the efforts for that collaborative conversation are driven by people's desire, by professionals' desire to make sure that they do have all the information. So I think, short of co-locating everyone again, which would be absolutely fantastic, I think at the moment midwives, health visitors have access to connected care, which is part of the summary care record for GPs. That can give them additional information. They're very good at picking up the phone and having a conversation where necessary. So they are at least able to have those conversations. But I fully accept and agree with your comment, Chair. When they were co-located, it did feel more cohesive. Perhaps we're doing the same now, but virtually. And I think we just need to get a bit more comfortable with that, I think.
Thank you. I mean, there's also the issue of, are people seeing their midwife regularly? Are the midwives accessible? Where are they seeing women? Do they have to travel far to see them? Are they keeping appointments? If they don't come, are they followed up? And also, thank goodness we've mentioned the health visitor here, who often just gets left out, but has such an important role in pregnancy as well as antenatally, and probably this is one, if you can refer to the midwives, but one for Neris, that there is concern locally about access to health visiting services, and I'm getting very confusing reports from women themselves about being told that they need to go out of area, go to Hungerford, Thatcham, whatever, and we know that picking up mental health issues it's important to keep in contact with the woman and the family, and to do the sort of ask the right questions, all those sorts of things.
Yes, thank you, Chair. Shall I just respond to the first bit about the about midwives? So I think are women accessing midwives? Yes, I'm absolutely confident that the midwifery service is as available as it A has ever been, and B would like to be, and I think we do quite well, actually. I think despite the rurality of West Berkshire, for example, so obviously looking at the map of Berkshire, geographically West Berkshire takes up half of that, so but I think our teams work very well to make sure that services are available and in locations that are at least accessible as much as they possibly can be. And on the subject of women in this particular cohort who perhaps are very unwell, they may be referred into the specialist midwifery service called the Poppy team, which is based at the RBH. And if they're not delivering at the RBH, they have a similar service, I believe, in Basingstoke and Swindon. I don't think it's perhaps quite as robust at Basingstoke, but certainly I know Swindon has a similar team. And in fact, that's a service where the midwife will go out to the woman at her home. So actually, if there were an issue around contact or travel or accessibility, then for those higher risk cases, the Poppy midwives would make that journey out to the woman herself. So I think we're okay there. I do think in respect of health visiting services, I'll default to Neris. I'm not sure if she's still on the call, but I'll default to Neris on that one, because I think I can give an overview of the support around what's provided through maternity and neonatal systems. There is collaboration that takes place there with our health visiting colleagues. I think it could be better. And I don't think that's a kind of, well, it's this person's fault or this person or this service, this. I think it's that collaborative communication effort, again, that we used to have in a one-to-one GP service that we don't have anymore. I think we need to get better at that. I think the rollout of more detail in summary care records will really help that. And I think that will make it easier for that communication to take place more real time. But yeah, I don't know if Neris wanted to pick up anything else about health visiting.
Oh, she's gone. Oh, I hadn't registered that she'd gone. Oh, that's a shame. We've had to lose Nerys. She's had to go. So, but hopefully we'll hear about from her in the future. I mean, there's a lot in this report, and from your experience, what do you think are the main issues in our area in West Berkshire that we need to address? Is it a staffing issue? Is it monitoring 6-week appointments, which is so important to see how the woman is getting on? You know, what are the most important issues?
Yeah. Thank you, Chair. I think I would say from referral into the service itself, I would say understanding what needs, you know, which cases need referral into the very specialised perinatal mental health service. So I think you know, Berkshire Healthcare gets a lot of referrals that don't meet a threshold. And I guess I should caveat that by, you know, my first comment around we should stop making women fit the service and make the service fit the women. But obviously it's a limited service and it's a very intense service. So obviously it does have to be reserved for the women that have the greatest level of need. I think Berkshire Healthcare themselves would say that actually they get a lot of inappropriate referrals and have to push those back. I guess for not just for West Berkshire, but I would say for the whole of Berkshire and probably the whole of Bob, actually, it's when the women are pushed back because they don't meet a threshold, is the safety net behind them as robust as it needs to be. I think for yourselves in West Berkshire, I think it is, because I think the services work really well together, but we can request the figures on the numbers of referrals that are received versus the numbers of referrals that are taken forward, and try and get perhaps a deep dive on what happens to the women that don't meet that threshold. And it would perhaps be worth looking at that, maybe say first quarter of the next financial year, to get a bigger picture. But I there's nothing of note certainly from West Berkshire, and the last I looked at the figures, there wasn't anything concerning to suggest that women that need the service are not getting it. So, but again, happy to take any action back on that.
Thank you for that. I mean, you've mentioned inappropriate referrals, and you've mentioned doing the checks for depression properly, asking the right questions. I'm assuming, you know, training for these things is so important, and you need time for that in the midwife and the health visitors working day. So hopefully that is addressed. You're less likely to get inappropriate referrals then.
Yes, absolutely. I think it is addressed actually, and screening around maternal mental health during the perinatal period is part of the mandatory training days for both midwives, health visitors, obstetricians, you know, mental health colleagues, GPs, anybody that basically is likely to have any contact with women during the perinatal period, you know, is or should be having training on what to recognise. As I say, sometimes it's those softer questions that don't necessarily lead to straightforward yes or no answers that can lead us to a decision that, you know, we might have identified a woman that needs help. So everybody needs to have that training. We're assured we collect data certainly from Berkshire Healthcare and from our acute trusts around their training compliance for mandatory training as part of their professional study days.
Councillor Foote.
Yeah, thanks, Chair. I've got a question about health inequalities and maybe social inequalities. In your data, you know, are you looking at that and giving us some good data and some feedback on, you know, pockets where, you know, due to, for example, social deprivation, you know, we've got more of a problem? Thanks.
Yeah, thank you. It's a really good question, actually, and I think you know, the equity conversation at the moment is making us think very broadly. I think historically we've tended to think that, you know, equity is around you know, our Black and Asian communities and where English is very poor. And actually, you know, we know that you know, in terms of ethnicity, you know, you are considered part of an ethnic minority community unless you are white British And I think taking that view has expanded the footprint of exactly what we need to be aware of. I think the other issue is that the landscape on this changes so quickly in terms of initiatives that are taking place within individual communities, what our voluntary organisations are doing, what our data is telling us, for example, from Embrace, data that we get through from service user voices such as Health Watch, maternity voices, partnerships, etc. We know that those communities are underrepresented in those arenas. And I think, that's a very clear demonstration that we're not capturing all of the data that we should be able to capture. I think ethnicity is now universally recorded as part of the records. But again, you could ask the question about accuracy on that, and I think that would be a fair challenge. I think there's also something again about that making every contact count. Are we checking on ethnicity? Are we really clear about what we mean when we say a woman or patient is from a particular ethnic background? Are we absolutely 100% clear about that? So we're not just counting different numbers of mass people just because that's convenient for us and that's what we've historically done. So I think our picture around what our equity piece looks like has grown, and it's meant that we need to be much smarter and clearer about the data that we pull. Within our maternity and neonatal services, we've got a huge piece of, well, in fact, we've got two huge pieces of work going on at the moment. One around our equity strategy, which I'd be very happy to send to you. It's a Bob-wide equity strategy, really good piece of work, and it really does go into detail around the different communities that we have across Bob. It won't single out necessarily West Berkshire, but it will give you a view across the whole of Bob. So that's one really important big piece of work that we're doing. The other that we're doing is interrogating our data around our communities and our populations, and also the data that is held within our systems. So, for example, what our GP surgeries have got versus what, for example, the midwifery records might say or the hospital records might say, to make sure that we're at least able to assure ourselves that we've got that we're all singing, if you like, from the same hymn sheet, which is it sounds very basic, but I think unless we've got that right, unless we've got that basic right, then we're a long way from knowing ourselves in terms of our population. Did that answer your question? It was a bit waffle, sorry.
Yeah, no, I think what I've got from that is that you are looking at all these aspects, and hopefully when we meet again at future meetings, you can expand on that and we can get some fine detail on that. Thanks.
Yeah, I'd be happy to do that. Thank you.
Councillor Jeffrey has a question.
There is a question, but mostly it's a comment. I've got to be honest. I'm very sold on Embrace, not only reading this, but hearing the way in which you have described it and the way in which you're trying to make sure that the multi-function and the doctor and the midwife and so on are all there working together. I think your enthusiasm fills me with a great deal of reassurance. One very specific detail is, if a woman requires inpatient help, preferably in a mother and baby unit, of which there are 2 in the southeast, Winchester and Kent. Kent's a very beautiful county, love it. It's quite a long way away. Winchester, well, was once the capital of England, but at the end of the day, that's a fair way from West Berkshire as well. Is that a significant issue? Do we need to have something at the Royal Berks or Great Western or somewhere like that?
Yeah, thank you. That's a really good question. I think, I'm sure the chair can remember these issues going back a number of years around the lack of inpatient provision that we have for our women who are very, very unwell. And the need to make sure that what is offered to that woman promotes bonding with her baby, which is, you know, hence mother and baby unit, because obviously it's really important that we keep them together as much as we possibly can, notwithstanding the safety issue and what's required to be able to do that. They are very, very expensive provisions, and I hate the money conversation. You know, it's ugly, and I feel like there isn't, you know, there shouldn't be any place for it, but I guess unfortunately everybody on this call is probably cognizant of where we are, and I think it's true to say that the chance of a more local mother and baby inpatient facility anytime soon is probably extremely unlikely. I think what I would say is the two units that we have are for the whole of the southeast, which is a big area, obviously, and you know, there is a push to not have inpatient support unless it is absolutely critical, because we know actually mental health wise that women do better when they're at home with their families, and the support that they have is given to them within their safe environment, within their home environment, around the people that they know and love. So yeah, I think if you get that right, if you get that in community support right, and I think actually Berkshire Healthcare do brilliantly on this. Actually, I think if you get that right, then actually we're doing pretty well. If there were to be any pullback on services that were likely to affect that offer, the perinatal mental health offer from the Community Health Trust, then yeah, I could imagine that, you know, what we have at the moment for mother and baby provision would not be enough.
Sorry, I haven't turned my microphone on. Oh, Councillor Langford has a question. Yeah.
Oh, I can't hear.
Sorry.
Oh,
Apologies. I don't know speaker's name, so I apologise for that. But I wonder if we could, you mentioned the Bob Equality Strategy. Is it possible to have a copy of that, please?
Yeah, absolutely. Thank you for asking. It's the perinatal equity strategy, and I'd be delighted to send it. I'll forward it on to Vicky.
Thank you.
Thank you very much. Thank you very much for that again. We will be revisiting some of these issues when we cover early years, which is in our next meeting in the new year, and we will have an opportunity to talk to Neris Probert, who unfortunately had to leave us today. So that will be some future work. So we won't be leaving these issues, and we'll be returning and learning a bit more about health visiting's role at the next meeting. So thank you very much for your time. Thank you for that.
You're welcome. Thank you, colleagues.
And now thank you very much to our two officers, Jodie Gordon and Kate Pike, who are here to talk to us about emotional well-being of children and young people and their work within the council. And thank you very much indeed for your time, and sorry about the delay in, never mind, over to you.
Okay.
Okay, and when you finish, you can turn it up.
Shall we introduce ourselves first? Is that the best thing to do? You can see our names.
You might remind us of your roles if you wish to.
That's fine. So I'm Kate Pike. I am a senior educational psychologist. I'm one of the managers of the mental health support team, and I'm also acting mental health lead for West Berkshire.
Hello. My name is Jodie Gordon. I manage the Emotional Health Academy team, and I also do a little bit of primary mental health work with the team as well.
Pardon me, Chairman. I genuinely didn't quite catch that. Do you mind saying it all again, Jodie?
Absolutely, sorry. Move closer. So my name is Jodie Gordon, and I'm the team manager for the Emotional Health Academy, and I do a small bit of primary mental health work as well with the team.
So we weren't sure what was the most useful thing to do. Obviously, we've written a report for today. We haven't prepared a presentation because that would have been really the sort of report. Is it helpful to just really quickly, briefly run through?
I think a sort of quick overview of your presentation while people sort of focus their minds and think of what the things they want to raise are.
Okay, yeah, that's fine. Shall I just run through it, Jodie?
Sure.
Is that easiest? So we just kind of gave a bit of a background to both of our services. So the Emotional Health Academy was established in April 2016, and that was in partnership with a range of sort of agencies. And following that, we were successful in 2019 for a bid to have a mental health support team. So we were one of the trailblazers, one of the first mental health support teams in the country. So we launched in January 2020, just ahead of COVID, which was an interesting time, as you can imagine, given that we're face-to-face service. And then we have since been successful with a second bid for a second mental health support team. So we cover 52 schools within the mental health support team. In terms of funding streams, we've included that in Appendix 2, but there's a sort of range of funding streams for the Emotional Health Academy, including the Integrated Care Board, Public Health and local authority. The mental health support team is pretty much all Integrated Care Board funded, ICB funded. So in terms of how we work together, so the emotional health triage meets every week, and it's really an open door policy. So any child or young person between the ages of 4 and 18 who might need emotional health support for mild or moderate mental health needs can be sort of brought to triage and kind of considered and thought about what their needs are and what kind of best next steps would be. You can see we've sort of covered demand a bit. We sort of did a year in the life of, if you like. So we took from September 22 to August 23 as our kind of numbers, just to give you a sort of idea of what a year might look like. So between the two services, we're around 1,500 young people that we work with. And there's, as I say, more details in the appendices about that. Lots of user feedback, lots and lots of positives. We try and, get sort of quantitative and qualitative data really as we're going to make sure we are having the impact that we want. I would say emotional health triage and academy are very, very busy, high referrals. Which means there is a bit of a wait. Jodie, you'd agree, I know. In terms of mental health support team, less of a wait currently, but we're a fairly new service, so I guess time will tell in terms of the demands that come through. So I'd say that's probably the most significant barrier for EHA. Certainly is the wait times. I don't know if there's anything else, Jodie, that I've missed. Yeah. So that's us in a nutshell.
Thank you. That was very sort of speedy and but you've done a good report here, and it's good to see the feedback from parents, teachers, and particularly young people in there. And that is so important to sort of let you know. Just before I take your questions, members, just to, she's gone again. Sarah Webster. She was there a minute ago. She is there. Okay. So we haven't got a report from CAMS because initially this was meant to be a joint presentation for various reasons. And Sarah might want to expand on that possibly before we start. We haven't got a report, although there's lots that needs to be said. But we have got Sarah here to answer questions. Do you want to say something quickly, Sarah, before we start on questions?
Yes, just to apologise to the committee. It's a combination of unplanned sickness in the team and scheduling to be able to get this report to today's committee. And so I've been speaking with Vicky and working around how we can best provide the detailed level update that we want to give you, whether that's at the next meeting or if we arrange a extraordinary session for members so we can brief in a level of detail that we want to be able to go through with you. Noting the breadth of services available when we talk about children and adolescent mental health services, there is a huge breadth, so a lot to cover. So no, just apologies that we don't have the formal update today, but I can try and answer questions or take them away to provide a follow-up answer on in between now and the next meeting.
Thank you, and thank you for sort of being there to answer questions. Right, who put their hand up first? Councillor Langford.
Getting, oh, thank you. Your page 6 of 13 has a beautifully illustrated flowchart. And this is no criticism of your report at all, but it is mind-boggling. And ever since I've been on the Scrutiny Committee, the one thing that has absolutely mind-boggled me is all the different organisations and where you go for this and where you go for that. And we had a little bit of that in our last presentation, and no doubt we'll have a little bit of that when we get our CAMS report. It is absolutely mystifying. And with all the good intentions that people have, and I'm sure they do, how on earth do we get this information out and useful? Because I cannot help believe that lots of people fall down the cracks.
Yeah, absolutely. I think, you know, some of it, even for us working within the mind-bogglingness of it is, you know, it takes time to understand. I think EHA and MHST, the very big strength that we have is that we are based within schools. We have really good relationships with those that we're working with, really. So we have very regular kind of meetings. We talk at kind of assemblies. We do lots of parent workshops. So as much as we can, we're getting our kind of voice out there, the interventions, talking about what we can offer, trying to kind of demystify mental health, you know, anything we can around that early intervention, really. So, yeah.
May I have a supplementary? Thank you, Chairman. A supplementary question, please.
Yeah.
Yes, okay. Thank you. And I'm sure that's true, but is it every school in West Berkshire? Because I have a school near me that is concerned that they're having to provide that type of help out of their funds, which some schools are getting out of West Berkshire funds. So is it every school in West Berkshire?
Every school in West Berkshire can access the triage, the emotional health triage. So as you said before, it's sort of the mind-boggling amount of information, and that's trying to sift through that and understand that can be really difficult for parents and for schools. So the triage is a first point of call for anybody who is curious about mental health services in West Berkshire and how to access support. So we would very much encourage anybody curious, wanting to know more about any service. We are very much there to be able to advise and guide people as to what would be helpful for the specific situation that child is experiencing. That's to say, available to every school in West Berkshire. The Emotional Health Academy and our specific clinical services are also there for schools in West Berkshire where there is a specific need, a direct or parental need in terms of mental health support for children and young people. We are again there to be able to provide that support. And the mental health support teams are in a number of schools across West Berkshire. So together as a service, we cover all schools in West Berkshire. The type of provision is slightly different, and the type of service you might access is different. And in the sense that there's the mental health support team and there's the Emotional Health Academy, and there's sort of subtle differences between the two. But I would hope that every school in West Berkshire would be able to access either one of those services.
So if some schools had additional funds, would they be able to sort of have a stronger service or
I'd say in an ideal world, yes, if they had additional funds and were able to look for specific services they wanted to use in their school, Emotional Health Academy is able to provide a level of trade and support for different schools. We are constricted, unfortunately, by our team capacity. So that does pose a challenge for us in trying to be able to actually have the time available to work with schools that do want to purchase time from our service.
Because my concern was more that, you know, if a school is wealthy, does it then, you know, get a better service? Hang on a minute, Councillor Langford. I'll just see if Councillor Jeffrey had a question and then we can come
I
back.
have a supplementary.
Oh, is it all to do with the same?
Yes, it is. I'm
Carry on,
so
okay.
sorry, Jem. So sorry, Councillor Jeffrey. You said that, I believe you said, and I'm just checking, there are 2 places to start. EHT and.
So the main point of call would be the emotional health triage.
So, and what is the telephone number for that, please?
01635
01635
519 018.
519 018. Anybody's name, or is that it?
David Hayne.
David
Hayne. He's our referral coordinator.
Great. Thank you very much. Thank you, Chairman.
I'll just add as well. Sorry, make sure all the microphones are up. So in addition to the mental health support team and the emotional health academy, as a local authority, we work with schools. Each school is encouraged to have a senior mental health lead, and we're working very closely with schools to encourage them to engage in the senior mental health lead training that's provided free by the government. So we're putting on in, trying to remember the date, and I can't, March, I think it is, a senior mental health leads conference to look at all of the kinds of support that are on offer. So we've got lots of partners coming to that. We've got the SAFE project, Time to Talk, Berkshire Youth, lots of different providers all coming and talking about kind of mental health needs, thinking about what schools can access. And at that time, we're going to start thinking about, do we want some kind of senior mental health lead network? What would that look like? To really try and start to encourage schools to talk together, to network, to, you know, to share practice as well, so that, you know, they can sort of support themselves from within as well.
That sounds good. Sounds as though you're really trying to address the issues. Sarah has put her hand up. So before we go to Councillor Jeffrey, want to comment on this subject? Thank you.
Yes, thank you. So on the point around mental health support teams in particular and coverage of schools, this is part of a nationally funded programme which we're part of, where the targets for school coverage at this point was about 35%, and we're currently at 50%. So we're exceeding the national targets, but it's been reliant thus far on national funding being made available for that. So we're continuing to pursue this. Obviously, as an ICB, working closely with our local authority colleagues to be able to reach as many of our children as possible. On the other comments about the complexity of the system, yes, there are a lot of different services, and I think on one hand, I think that's necessary because of the range of needs and the range of professionals and clinicians and colleagues that need to be involved in this. But what's important, and that we're continually striving to do, is that it doesn't feel that way for the people using our services. So the triage services that have already been mentioned are really, really important in this, and we're always setting ourselves the ambition of how do we help navigate people through our system so it doesn't feel complicated and it doesn't feel fragmented, but it's being managed in a way that's appropriate for each of the different sort of needs that we're addressing.
Thank you, Sarah. Thank you. Councillor Jeffrey.
Well, number one, I was definitely brought up to know that it should be ladies first. I've got no problem at all with that, Madam Vice Chair. And an awful lot of what you've asked is actually where I was at too. Because one of the things about this, I was trying to understand, where does this sit in regard to CAMS, when CAMS is, as it were, shown as being a part of it? And for many, many years, my understanding has been that CAMS has just been utterly overwhelmed. It's not even been under pressure. It's just been overwhelmed, and that, you know, children are coming through with, you know, in 2 years' time, you'll have an appointment with CAMS. And in terms of mental health, that's just, it's heartbreaking. It's ludicrous, but it's just been where we've been at. And yet, I now see that there's well, I'm looking at more than £1 million of funding coming in, which I'm delighted by. Is that just, are we being treated as a pathfinder? Are all education authorities and health authorities getting hold of this kind of money? I'm just I'm perhaps like the Vice Chairman, I think I'm a little bit confused by what's going on. I'm delighted that there should be some money going into it at last and that it's being taken seriously at all levels. But I'm not quite following how it's all hanging together and where it's coming from.
So it kind of the mental health support team side of it came from the Green Paper. So it was very much around kind of that early identification, early intervention. It sits in different places depending on what local authority you are. So you basically place bids to have a team, and then it kind of gets sorted out like that. So some local authorities or some ICBs, it's held within health, some it's within education, so it varies a little bit. But it is government funding that was provided specifically around early intervention and kind of early help. So my understanding is it's here to stay.
Councillor Drummond, do you have a question?
Yeah, thank you, Katie and Jodie. On page 9, reasons for closure. 23 did not engage and 14 dropped out. Can you tell me why? Is it too hard to handle? Or low-hanging fruit? You got the low-hanging fruit with the rest of the cases, and this is a difficult cases which you can't manage. And by the way, I'm not having a go.
Thank you for your question. So these are very broad brackets, I would say, in terms of the reasons why cases might close. So did not engage or dropped out of treatment, essentially, could be for the same thing. We would see a do not engage sort of reason for closure as somebody that hasn't responded to our communications, hasn't taken up the offer of support that we felt was best appropriate, or hasn't attended the sessions that we might have provided. That would be to someone as described as not engaged in the service. Dropped out of treatment would tend to be somebody that may have started some form of support, or may have started communications and engagement with us, but for some reason has decided not to continue, and we haven't been able to establish if there is a sort of any progress or any specific reason why they have they've chosen to not continue. So we've described that as dropped out without any proof of outcome or sort of improvement.
Thank you. And also on the feedback, it's all positive feedback. Has there been no negative feedback at all? I'd like to see some of that. Because I remember when I was at school, it was little Johnny and Mary at the front of the class, always putting the hand up. It's reaching little Michael at the back of the class, and it's always hard. But is there no negative feedback at all?
I wouldn't say any specific negative feedback. We get comments and we get concerns raised at times about specific things. This feedback that you're sort of looking at now is very sort of specifically requested from the work that we've done. I couldn't say that we have ever received negative feedback as a result of requesting it. Feedback specifically, we do get concerns raised. Potentially there's a need for us to maybe sort of record some of those comments. They mainly would be around concerns about wait times and children maybe not being able to access exactly what they need at exactly the right time. Again, I can make an effort to try and record that information if we feel it's helpful.
And on a question from Councillor Langford on academy schools, do they partake? Is it just junior schools that partake or senior schools? Or is you don't deal with academies?
Yeah, so I guess all schools in West Berkshire, so primary schools, infant schools, secondary schools and academies. And we also try to provide some support to the specialist schools and alternative provisions as well.
Thank you very much.
Yeah, following up a little bit on that, obviously if people don't engage, young people don't engage, I would imagine you don't just say, oh, that's it. You sort of follow them up, give them keep the door open, because as with adults, it's not always the right time to engage, is it? But obviously with children, you're a little bit more sensitive of what might be going on in their lives. But I imagine you do try and get back to them.
Of course, we would absolutely try to understand the reasons, what reasons why they weren't able to engage. And we have a re-referral process very open to people coming back to us in the future when they do feel ready to engage with services. So absolutely, we encourage people to come back to us whenever they feel is appropriate.
As well, sorry, just one example. We had a parent that was going to be doing one of our parent intervention courses and did not engage, so didn't reply to any phone calls or emails. We tried through school and it wasn't happening. She closed to our service, but through regular conversations, we have what we call mental health surgeries every half term with the senior mental health lead. And through conversations, it just became apparent that there was a lot going on at that time for that family. And I kind of offered to say, well, I'll give Mum a ring if that's helpful, just to kind of understand a bit more, which is what happened. And then Mum has actually said she'd really like to engage. She's going to do it on a one-to-one basis as opposed to a group intervention. So we kind of keep touch with those still. It's not that they're forgotten, but they might, like you say, they might not be ready at that time.
They might not understand, and they might want to feel they got to know you. I mean, one of the negative points that the young people say, I mean, you can see the parents are 100% and the school 100%, but the young people who are having the service, they're a bit more realistic and saying, well, I would have liked the same practitioner each time and things like that, which obviously one can understand. So their comments are a little bit more realistic. Councillor Foote has a question.
Yeah, thanks, Martha. Yes, two questions really. The first one just is an observation again, really. It's my impression, certainly with young people, that I've been surprised at the response rates to questionnaires and things, and it seems to me that they're actually quite open to engagement. And whereas previous generations and things, and maybe particularly when you're talking mental health issues, they're not very forthcoming. But it seems as though my empirical impression is that children or young people are better at actually voicing what's going on. So I'd like your comments on that. And the other thing is, certainly from our educational colleagues, we're well aware of the fact that the long tail of COVID means that young people going through education from preschool that were involved in lockdowns, educational colleagues say this might well impact their whole experience throughout the whole of education. And that suggests to me that there may be really increasing demand, possibly exponentially, in mental health requirements going forward. Could you elaborate a bit on that as well, please? Thanks.
So if I start with the engagement side of things, pupil engagement, absolutely. And I think every time I'm in schools, it's so apparent that it's a conversation that's regularly had. Young people are very much aware of this. A lot of schools now have kind of mental health student ambassadors, sort of committees with pupils that are involved and engaged. So definitely I would agree with that. And we work very hard, both of our services, to include pupil voice in all that we do, really, what we're offering, what that looks like, how we get word out, really. So yeah, absolutely agree. Second bit about COVID, I mean, it feels like there's huge increases, really. I would say the biggest one for me that I'm noticing is emotionally based school avoidance. So young people who are finding it hard to access education, finding it hard to sort of get into school. That's definitely on the increase. But I imagine numbers will increase as well. I don't know if you've seen anything to suggest that, Jodie.
One of the functions of the EHA is we work quite closely with the EBSA advisory team, as Kate mentioned, emotional based school avoidance, and their referrals coming through to that service tend to be young people who are finding it difficult to attend school due to anxiety sort of related reasons, but also have sort of a diagnosis or some neurodivergence aspect to their lives, which adds a level of complexity. So I would say that's also what we're seeing more of, as well as children and young people coming through who have a neurodivergent aspect to their lives. Yeah.
Thank you. Could I just clarify? Did you say emotional risk avoidance? Was it, or what was it?
Emotional based school avoidance.
Oh, okay.
Emotional what?
Emotional based school avoidance.
Meaning they're not just sort of, I can't be bothered. They actually have a real solid reason for not attending school.
I have known a youngster like that very recently, so I understand it. Yeah.
Okay. Obviously, the Emotional Health Academy is sort of meant to be for sort of mild to moderate problems, hopefully preventing things worsening as well as addressing things early on. I mean, we're aware that complex needs obviously will move on to CAMS, and there is this long waiting list. So obviously one of the questions, and we did have a public question related to this or related to a specific area that gets referred to CAMS, you know, is about what sort of support to the more serious end of the range of children that are referred. And the question that the public member of the public sent to us was, how are we preparing funding primary and secondary schools for students who are awaiting their diagnosis via CAMS for ADHD and ASD? The current wait time is nearly up to 3 years, and the children and staff are struggling with larger class sizes and lack of educational funding, especially with budget cuts, etc., etc.
So I mean, I guess we can answer from an early help perspective, I suppose. But in terms of the support in schools, we provide intervention around understanding those needs. You know, we support and train staff. We work with parents. We work with young people. So I suppose for me, it's about how the school and how the young person is supported to manage their sort of experience in education, really, isn't it? Whether they're diagnosed or not, I suppose is kind of you know, it will happen or it won't, but they've still got the same needs, whether they've got a diagnosis or not. So I suppose it's about understanding the support. It sounded to me like it was around ADHD and ASD and that understanding.
Obviously it was about ADHD and ASD, which is a big issue with a lot of people. You know, if there's problems, people just like the label, don't they, sometimes, and it might not always be the case. But until that's confirmed, they're wondering how to handle, you know, the child, you know, the difficult behaviour. And what you're saying is, don't just think it's about the label, it's about the behaviour and how you work with it. So people get hung up on the label, don't they? And want that confirmation that they can't do anymore because it's a problem. Yeah.
I mean, I think, you know, we have the ASD advisory team, we have the educational psychology service. There's lots of professionals that would kind of support and work and train around that need. Has someone got? Yeah.
Right, Sarah, you want to comment? Yes.
Yes, so from a kind of neurodiversity pathway perspective, which is how we term things such as the ASD and ADHD and wider needs, there's a spectrum of services. So there's a number of services that Berkshire Healthcare provide that are available to all. So they're universally available services, and a lot of it is support for parents and schools, with online resources, and they've run a number of workshops and things, and generally these services are excellent. And when you look at sort of national comparators, the services Berkshire Healthcare provide for those universally available services are really excellent. We are struggling at the moment with an increase in demand for these services. So if we looked at the summer period this year compared to summer last year, we've seen a 40% year-on-year increase in referrals into these neurodiversity services. And whilst we've been putting a lot of effort and some funding into being able to increase capacity is only increased by about 14%, which generally you'd see as an excellent increase, 14% increase in activity. But in the face of 40% increase in referrals, it's something that we're continuing to work on. So it's very much on the high profile, high on the agenda for resolution. But this is a national issue. It's not something that's unique to Berkshire. It's being felt across the country in terms of that increasing demand for these services. And there's work going on at a national level to therefore look at what the national answer to this is in terms of the model of care and assessment, to make sure we are able to cut into those waiting times.
Thank you very much for that. We did look at the Berkshire Youth Survey, which was quite sort of impressive. Nigel was referring to the high response from young people, and it was impressive to see how many people responded to that, and that mental health issues were very high on their agenda. And that talking to some young people recently, we're fortunate enough to have the Waterside in our community, and we bob in there every now and again. Conversations with young people that we've had recently there on a counsellor's visit, they were just telling us that they think their generation, they were talking as though, they were, their generation they felt was the first one that seemed to be comfortable about talking about mental health issues, and they had networks in school, they were addressing things. So, which is really, really good. Whether that affects people that have come through to you, or whether they're sort of dealing with things themselves. There is something here about the SAFE project. Is that about young people working together? What's that about?
So the SAFE project is I think it's a Thames Valley wide service, and they specifically provide support to children and young people who've been affected by crime. They also support children and young people who may have experienced bullying, or where there are specific issues around child on parent violence. So it's quite specific to sort of experiencing victimization or crime in any way.
Specific, yeah. Okay,
I may, Chairman. It's probably a little bit following up the comment or the question that you were just asking. On page 12 of 13, I did just write down, are there negative comments too?
Is this a comparison of West Berkshire MHST? Is that the report there? Yeah. I have got the report, if that's helpful to send across. The full report. I don't know if that's something that's helpful to have. I'm assuming that's okay to send. I'll need to check.
Yeah,
I'm sure it'll be fine.
Yes, please. Is this going to be 494 pages?
No, it's not. It's not. There's not huge amounts more than this, to be honest. And I think there are sort of other bits either side of it. So yeah, this was the kind of the main standout bits, I guess, for MHSTs. We do perform well in West Berkshire in comparison. I have my theories about that. Some of it being the fact that we sit in education and we're very well versed with working with schools. So I think that makes a big difference in terms of the kind of relationships that are coming out here really, and how we work with senior mental health leads.
Do you have good links with the voluntary sector, particularly we mentioned the Waterside, but with the youth service, how do you work with them? Because they, well, I did come across somebody actually quite recently who had, I don't know whether she'd been referred to the youth service at the Waterside, but she certainly found the conversations and the activities she got involved in were very beneficial to her mental health.
Yeah, so particularly Berkshire Youth, we're trying to look at how we, sort of increase our sort of working partnership with that team. We have an emotional health worker who sort of joins their youth cafe sessions. I think we have tried to have somebody there weekly, just to have a representation, at that sort of session for those young people, so they can sort of become familiar with somebody from our team. I regularly sort of liaise with Kelly Leach, who's the manager of Berkshire Youth, and what we've realised is that there's some really great sort of facilitation that Berkshire Youth can provide when they've maybe identified a child that needs a little bit of help, and there's an emotional health worker there who could, they could be starting a conversation with. It helps the young person to feel a bit more comfortable about the possibility of accessing mental health support, and also gives them a sort of more of an understanding of what that person is like, sort of somebody to talk to sort of understand. And that way, I think they maybe increases their confidence to be able to actually engage or sort of seek support for the needs they have. So we are trying to increase our presence at Berkshire Youth, but that's one thing we are currently doing at the moment with that team.
That sounds really good, because they are a great team there. Obviously, one of the things, I think Nigel touched on this with the previous report, was the cost of living and inequalities. Is this something that you're seeing in your work? Is this making it much more serious to engage? Are you changing the way you work in any way because of these pressures? Or does it just mean there's greater demand? Or maybe this is sometimes one of the reasons why people don't engage, because there's too much going on in their lives, isn't there? Yeah.
For sure, absolutely. Yeah, we would say that sometimes we might have individual conversations with families where they need to prioritize for parenting to prioritize their work over missing time to go to sessions, or young people and children in schools. That might be affecting the dynamic of the family. I would say I'm looking at how we can try to increase or sort of expand our offer given the financial sort of situation. But from our perspective, the general changes we've seen have been increase in demand and increase in wait times.
It's a shame about the wait times, yes. But things like Berkshire Youth, that's a sort of generic service for everybody. So making sure that young people know about that and that it's welcoming all, and hopefully it is a welcoming place. At least they can have informal conversations there while they're hopefully waiting for something more serious. And I don't know whether there's some sort of, not mentoring's not quite the right word, but sort of like a buddy system or something to help people. Yeah.
So we do train peer mentors as well. That's part of one of our interventions. So we do peer mentoring training, and then we sit in the initial session. So the school are part of the training, so they know kind of what it looks like. And then we sit in for the initial mentor-mentee and just support the mentors through that first bit, just so that if there are questions that come up, so it went like this, how did I manage it right? So we do a little bit of kind of supervision as well. So then they're kind of ready to go out and mentor. Yeah.
Yeah, thanks, Chair. Just before I forget, actually, Martha's sort of, touched on this really. I think it's a really great idea that the Emotional Health Academy have a link with Berkshire Youth because, as you know, they've got their outreach workers, and they're very good at seeking out where young people go and getting the hard to reach, the kids that are not attending school and that sort of thing. And I think what's so good about the Waterside and that sort of environment is it's a safe sort of place for those conversations. They've got lots of rooms, they do lots of activities, and it would seem to me a great idea for maybe one of your health team to just sort of be there, and the kids, the young people get to know them, and then they can have those conversations. And they've got some really quite exciting stuff about how they bring people back into more of the mainstream and get them engaged in things, and keep them away from going down the wrong track, really. Yeah, thanks.
Thanks for that, Nigel. One final question, because I'm sure you've been here a long time with us, but there's so much we could talk to you about. I think, what about when children transition to adult mental health? That's always a problem, isn't it? Is that something that you're finding is an issue, and how do you manage that?
I would say we struggle to find the equivalent services in adult mental health. Sometimes, so there isn't maybe like an early help or mild to moderate service that's sort of accessed in the same way as mental health support team or the Emotional Health Academy. That can be a challenge in finding the right type of support for particular children. We generally sort of are aware of the the most accessible services, so talking therapies and sort of discussions with other health professionals or GPs. That tends to be our main sort of support for children and young people, and we advise about what that could look like, whether that's online support or speaking, sort of having counselling sessions over the phone or something like that. So we probably don't know as much as we should about adult mental health services, but we certainly talk to those young people sort of 17.5 to 18 who are transitioning out of our services. We try to give them those sort of the information about the early steps and the first things we would recommend, which is to say talking therapies, speaking with the GP.
Because we have a quite distinct, we have a mental health action group, which is sort of under our health and wellbeing board. Councillor Crow has gone. I don't know whether they could help with some sort of transition thing. They are sort of, across the board, but they're very much adult services. It's very much adult services, children's services, and never the two sort of meet really. But maybe it's worth contacting them in some way just to see whether there's any work that could be done.
Yeah, and I'm just thinking about, you know, sort of 18 plus in education, employment or training, and just thinking about those young people, and, you know, maybe there's scope to be talking in schools as they get to kind of, you know, end of sixth form or college or even training programs, and just thinking about, you know, what the accessibility is like might be.
Sarah wants to comment. Sarah?
Yeah, just to provide some assurance that this is very much something that Berkshire Healthcare are actively looking at as well in terms of transition from children's services to adult services, and it's a topic of conversation when we have our children's partnership boards and through the associated boards that you've just mentioned in terms of the mental health groups within the Health and Wellbeing Board. I think there's a reason why we have to do things slightly differently for children. There's a level of safeguarding involved that necessitates an approach. But what we absolutely recognise is that children don't suddenly turn into a different person the moment they hit a certain age. And so how do we smooth that transition is one of the ambitions that we want to keep working on and improving.
Very much for that. Just before we thank you and say goodbye, you mentioned talking therapies a few times, and what sort of comes into my head is talking therapies because talking to young people is quite different from talking to adults, really. I mean, that doesn't mean you've got to speak in some sort of cool jargon or something, but, you know, the way their minds work, and I'm not an expert in this, so with people who are accessing talking therapies, young people, is there special training for those particular therapists, or do they just go to the therapists that adults access?
I mean, yes, there are some. So Time to Talk, for example, the counselling service in West Berkshire, they would be working with young people up to the age of 25. So I would imagine that the training level of their counsellors is going to be sort of accessible for their whole age range from 11 to 25.
Right. So when you mention talking therapies, you mean Time to Talk?
I mean Time to Talk as a service you can access via talking therapies. Yeah. So they do sort of have. I'd imagine they'd have. You know, therapists specific for different things. If there's more adult themes coming through, they may work with a specialised counsellor in that area. But I'm confident that they have a high level of counselling sort of training, so would be well equipped to talk to sort of young people who are transitioning into adulthood. I can't say much else about talking therapies, unfortunately. I wouldn't know a huge amount about their approaches or their level of training, unfortunately.
In terms of the specific detail for talking therapies, that's something we can ask Berkshire Healthcare to provide the detail on, but I would just say that any services that are available to children will be suitable for children in terms of the skill mix and the clinician training.
Thank you very much, Sarah. That's reassuring. Thank you very much. And thank you ever so much for your presentation, and it's really, really interesting. I mean, we could have asked more questions, and thank you so much for waiting, and sorry about the sort of delay earlier. We will be learning more about CAMS at a future meeting, because we're going to be focusing on early years for our next meeting. So thank you very much indeed, and hope to see you again sometime. Thank you. Good luck with all your work. We're now moving on to item 10. Thank you, Sarah, for being here for the whole of the meeting. And this is a report back from Sarah about the Integrated Care Board. Bob, thank you.
Thank you, Chair. So you will have had a chance to read through the report, and I don't propose I read through this line by line. So I'd like to spend most of the time just with questions or anything for clarification for members of this board. I suppose the one thing I really would highlight, though, in terms of an ask for engagement is around our primary care strategy. And when I say primary care, I mean the collection of services that include general practice, community pharmacy, dental services, and optometry services. We are currently looking at our strategy for these services going forward into the future to make sure they are sustainable, fit for the future, and meeting the needs of our residents now and in the future. At the moment, what we are engaging with the public around to collect views for people's feedback on the current state of services and their experiences using them. So there's both at an ICB level covering the whole Buckinghamshire, Oxfordshire and Berkshire West patch, a route to engage in that's outlined on the paper. There's a Bob ICB website, and we are also outreaching into the communities to seek some feedback. In addition, locally, colleagues at Healthwatch, and thank you very much, Fiona, have been doing a piece of work to do even more outreach into the communities to gather that richness of data locally around use of primary care services. So I just wanted to highlight that one in particular and ask if you would like to, both in personally and when you're speaking to your constituents, mention that this is happening and ask if they would be able to engage. But other than that, I think the updates are hopefully fairly self-explanatory, but I'm very happy to take any questions on anything else in our standard update. And I think we're going to be bringing this now to every meeting going forwards, just to keep HOSC appraised of the developments within the ICB. I say that I just need to check with Vicky that we're on that is the plan in terms of the forward plan. I know we do this through the health and wellbeing boards as well.
Thank you very much for that. I'm just trying to find it. I think it was on page 19 that you talk about funding for a community wellness program, a sort of outreach program. Which I think is a good idea, but I was just wondering about where this might be conducted. And again, thinking about the rural nature of West Berkshire, the areas again which miss out, often the rural areas, and wondering whether you're going to be taking this out of the way places and not just Newbury, Thatcham, etc.
Yes, so this service is something that we are rolling out across the whole Berkshire West patch, but we're tailoring it for the needs of the individual areas. And it's something that our integration board that feeds into the Health and Wellbeing Board has been leading. So it's very much a team effort between all of our organisations, and public health have taken a huge leadership role in this, for which we are very thankful. So I don't have the list to hand of all of the specific venues or locations that the service is going to be delivered from, but we're absolutely adopting that ethos of going out into community cafes, libraries, other areas where people are already going, as well as inviting people who are at higher risk of cardiovascular disease in particular to come along. So it's a dual effort, because we know sometimes some people will respond to invites, others won't, and prefer to be able to drop into venues when they're already going to be there. So it's a combination of the two.
And you have the practitioners to do this? Will you possibly be using, I'm trying to think of the word, ancillary staff, or staff just trained to sort of do the wellness check, rather than using more qualified staff? Is that something you're thinking of doing?
Yes, so in West Berkshire we are commissioning a tender process has been underway, being managed through Public Health to commission this service from a provider. So it will be a combination of different skills within that team, but we've not specified that it needs to be an overly medicalised service. This is for people who will feel like champions within their communities, who are able to access the appropriate training to be able to provide these health checks and have the wellbeing conversations, signpost onto other services, and update our shared records with the findings, so that everyone's aware of the output from the health check, and it's all integrated into our existing services, so it's not a bolt-on.
Would you consider going into pubs? This is something that's been discussed in the past,
I'm sure, so I can't comment on the specific locations. I'm sure that will have been considered by colleagues through the integration board, but I can feed that one back as well, because you're right, there are examples nationally where we're having conversations around particularly men's mental health in pubs in certain communities, and that's had a big impact.
Yeah, thank you.
Hairdressers and salons are other areas where training people to have those sorts of conversations so there's an awful lot, and John Ashton, your Director of Public Health, has a wealth of knowledge in those areas as well, and it is part of the conversations on this.
Thank you very much. Councillor Jeffrey.
Thank you, Madam Chairman. Was it 5 years ago now that I can remember the previous chairman that I challenged him on the fact that the health inequalities within West Berkshire took my breath away. I hadn't realised just how great they were. The ward in which I live in Thatcham has, I think it is, a 10-year differential in life expectancy for males than most of the other wards in the whole of West Berkshire. And Rick, who it was, to my amazement, came over and agreed with me that we had to do something about it. And of course, we then went plunging very rapidly straight into COVID, and the whole of the world has changed, and we're still picking ourselves up and shaking ourselves off. But I do hope that inequalities funding is not just going to be looking at whether somebody has a high or a low income, but whether or not they're in an area where we can actually perceive that there is a significantly earlier death rate, younger death rate. Is that coming out of all of this as well, please?
Yes, absolutely. So we know the wards that have where our residents' lives are being cut shorter than people who live in other wards. And so part of the work we're doing is making sure we're taking these services into the hearts of those communities. But also it's wider than this. We know that sort of someone's health outcomes are not just to do with their interaction with health services. There are the wider building blocks of health that come together that ultimately impact on someone's life expectancy and their healthy lives lived. So I know there's some work in the council around sort of health in all policies that I hugely support, around how are we thinking about how we're addressing health inequalities through all the work we're doing. And I know that's something that you as an authority are very much committed to, which is very welcome.
Thank you very much. I mean, there is a mention in your report about community pharmacies and expanding care into them. And I think, again, we keep getting the comment about how can pharmacies cope when, you know, when the service is being stressed at the moment. I mean, we are hoping that we might get a new pharmacy in Newbury, but even so, I'm not sure. I mean, do you know whether any pharmacies are actually functioning in this way, giving this extra care? I've never seen anybody in the little room in Boots in Newbury, you know, having a little chat with the pharmacist. He's too busy doing his job. So is there any survey out there showing whether anybody is able to provide this extra care, which is supposed to relieve the GP?
So our pharmacies provide a range of services, and I think at a future meeting we were going to do a deep dive into pharmaceutical provision where we can go into this in more detail, because I think that would be helpful, and we're certainly doing that through the Health and Wellbeing Board in February, I believe. So part of the exam question we're trying to answer is, for this to be true and for our pharmacies to be able to provide these services that they're absolutely kind of able to do in terms of that clinical expertise, how do we make sure that the capacity is in the right place and that we have the level of resilience we need in those services to be able to meet that demand? So part of the strategy, the primary care strategy that we're working on at the moment, is looking at that, and pharmacy is a key strand in that work around how we get to that end goal, noting at the moment that, as with many of our services, pharmacies are feeling the strain of increasing demand. Obviously the work that's ongoing at the moment to shore up the current provision is really important, as well as thinking about where it goes in the future.
Thank you very much. Councillor Ford?
Yeah, thanks, Martha. Sarah, could I ask your dental provision? I mean, we've spoken just now about pharmacies, dentistry, certainly NHS dentistry, and accessibility for residents to access NHS dentists is so difficult. We live in a part of the world where there's a fair amount of affluence around here. Young dentists, you know, who've graduated, come out with a large amount of student debt. You know, it's not hard to understand that they don't particularly want to work in an NHS setting, but would rather go into private practice, you know, to basically help pay back their loan and earn a living. Dentistry is very different to medical practice, in that all dental practices are run as businesses, and if they don't make a profit, they go under. And I've done a little bit of sort of background research, because in a former life I was a dentist, a specialist dentist, and it seems to me an almost insurmountable problem that needs to be addressed nationally, and we don't seem to be getting a lot of traction in that regard. Could you just elaborate a little bit on what the state of play is regarding the provision of dental services, in the Bob area, please? Thanks.
Thank you. No, and this is another important area where we know some of our residents are struggling to access dentistry services in the way that we'd want them to be able to. You're right to highlight that dental practices are that they're not the same as GP practices, and that they don't have responsibility for a defined list of people. That technically their responsibility is for people who are receiving a course of care, and in addition, the dental practices can choose whether or not to provide NHS services along with their private services. And over the past 12 months, we've had a number of dental practices across Bob who have handed back their NHS contracts for a number of reasons that you've just articulated. So there is work nationally looking at kind of how funding flows into dentistry through the NHS and how we contract for that in a way that hopefully can be a bit more flexible. In Bob, we have taken the steps of doing what we've called flexible commissioning, which is where we are enabling dentistry practices who signed up to this to use some of the time that they're being paid for slightly differently in a more flexible way. That means they can meet the needs of people who may not have been registered or need to be registered as new patients into that practice, and in particular being able to meet some urgent demand as well. So I can provide some more detail about that if that would be helpful. We've got a paper that summarises all of this. But you're right to highlight that this is something that we are actively considering as part of the primary care strategy, because dental health is so important, and so important we get this right.
Yeah, thank you. That would be really kind to share that. That would be very helpful. Thank you.
Councillor Drummond, you had a question.
Yeah, on page 16, on the challenges facing primary care across Bob, point 3, general practice staff would like to spend more time on prevention and chronic care from 50 to 68%. Is there a time frame for that? And how are they going to do it? Or does that come under expected later in December?
So that's one of the aims of the strategy that we're developing at the moment. How do we, and it's linked to national policy, which I think is going in the right direction around how do we empower our general practitioners to be able to do more preventative work, and supporting our communities to stay well and helping people who have long-term conditions to manage those in the best way possible. So being able to make that shift is reliant on a strategy that enables that and also meets that sort of same day urgent need that is such a pressing challenge for us as well at the moment. So I can't confirm the timeframes for making that shift in terms of percentage of time spent, but the strategy that we're consulting on at the moment and developing and will continue to consult on with yourselves and the public will hopefully provide some of the answers to getting us to that position.
Thank you very much.
Thank you very much. Any more questions, members? Thank you very much for that, Sarah, and thank you for attending the whole of the meeting. Thank you very much indeed.
No, thank you very much for having me.
Thank you. And now, last but not least, almost last, Fiona from Health Watch. Again, thank you very much for sort of hanging on in there, Fiona. We have Fiona's report on page 43. Would you like to highlight anything, Fiona, in particular?
Hello, Chair, and hello to everybody there. I just wanted a quick overview, if that would be okay, Chair.
Yes, please. Yeah.
Okay. So as Sarah very kindly mentioned earlier, we have been doing a GP access project in the whole of Berkshire West. So that includes Health Watch Reading and Health Watch Wokingham as well. And so we've been out and about in the community speaking to lots and lots of people. We've held focus groups and we visited vulnerable groups as well, along with having an online survey that people could fill in. And we've had 300 responses across the patch so far. That's across all three, over 300 actually, which we will be closing this. We were thinking of about the 15th of December. We might give it until sort of Christmas Eve and close it then. And then in January, February will be analysis and report ready for March. So it's actually gone incredibly well. People have been very interested in it. There's some very good themes coming out of it already that we can see, which I won't share just yet. But it's across across the whole of Berkshire West is very, very similar. And this was to do with the new roles in the practices that we were talking about earlier. People's understanding of what's been going on, the care navigators or the care coordinators, their new role. And I think people understanding that they've actually had training to be able to triage now. It's not just a case of they're the receptionist and they're asking you lots of personal questions. They're doing it to try and help you. And these are the sort of things that the public perhaps didn't quite grasp initially, but it's getting that information out there now. And once they know about it, they're absolutely fine and don't have a problem at all, which is lovely. So it's actually quite it's been very interesting speaking to everybody. Going on to the next bit of what we're doing now, we've been monitoring other issues within the West Berkshire and via the feedback that we have coming in from the public, and also what we hear on the ground as we're out and about. Cervical screening, obviously Health Watch England has been looking at this. It's an all-time low nationally, and it has been raised within Bob, and I'm having a discussion with Sarah Wise in Bob about this currently. There's a possible piece of work coming out to do with this. Phlebotomy. I have been chasing RBHFT for quite a long time now to get an update with phlebotomy, and I'm finding it very difficult to hold somebody, find somebody to speak to about it. I am continuing to do so, and I will get there in the end. It's just proving to be a bit of a up and down course to get there. So that is still very much on our radar to do. And looking forward, as Sarah said earlier, pharmacies, we have again been listening to feedback from the public, and they are concerned about wait times at pharmacies. They're finding they're waiting a very long time, and obviously with COVID cases out and about again, there's the people are waiting outside rather than going in, and obviously the pharmacies are quite small anyway. They are also concerned about the information is coming out to the public about the services that the pharmacists can provide, and they are actually saying that, well, how can we get the services that we're being told to do when people are waiting in line? I haven't got time to go and stand and do things like that. So we're listening to this feedback, and on the back of this, we're actually thinking we're talking at the moment about doing a piece of work around this next year, possibly. It's not on our current work plan. It would have to be as an addendum to our work plan, or actually going into 24-25 work plan, which obviously is not starting till April. So again, we need to look at that. So yes, the work plan, going on to the work plan for that, we're going to be taking into account the primary care strategy, and we will also be putting out to the public again, in collaboration with Health Watch Reading and Health Watch Wokingham, a survey asking what people's priorities are in health and social care, which will obviously go into our work plan. And that will be coming out. We will start working on that in January, ready for hopefully February. Sorry. Yeah. So that's where we are currently, and happy to.
Thank you, Fiona. There's a lot going on for such a tiny team.
Exactly. Yes, we're very busy. Chair, we're incredibly busy.
You do an awful lot. Have you still got the champions, Health Watch champions that we used to have, or
not at the moment? No. Health Watch has undergone in West Berkshire a bit of a change over the last year. Obviously, I've come into post now. Currently, we only have 2 members of staff at the moment, and we are looking to employ a new member of staff, hopefully in the new year. But we're getting lots and lots of work coming in, and obviously with being such a small team, there's only so much that we can do, and we are not full-time either. We're both part-time members of staff, so it's it's keeping us busy, shall we say.
No, thank you for your hard work. Yeah, I mean, I know you lost a member of staff in very sad circumstances.
We did, yes, we did. Yeah, and yes, that's left a huge hole in our team, both emotionally and physically. Yeah, absolutely. Very sad.
Thank you. We've got some questions here. Councillor Jeffrey, and I know I've got Councillor McCrae on screen, so I'm not quite sure. Councillor Jeffrey, anyway.
Thank you. On phlebotomy, I would just ask the question: what is the issue? That there can be problems with phlebotomy, there can be no problems with phlebotomy. I can't understand how West Berkshire Community Hospital could not be responding and speaking to you. And on pharmacy, obviously, I don't suppose there's a person in this room, I should think it's a person in West Berkshire that hasn't encountered problems with the pharmacy services. The biggest single problems I think we've got is that Boots was sold to an American asset stripper, and Lloyd's was sold to, I think, another American asset stripper. So two of the biggest pharmacy chains in the country are both in the hands of American asset strippers. But clearly, our problem is to make sure that we have got sufficient pharmacy services across the piece. And I'd congratulate that you are going to go looking at it, because it is certainly an issue that needs a great deal of attention. But on the phlebotomy, I'd be really intrigued what exactly is going on, that a part of the health service, West Berkshire Hospital, is not community hospital, is not coming back and responding to you.
Thank you for that, Councillor Jeffrey, and good luck. And I'm sure you'll get there. I'm sure you know who to contact to actually sort of get them to respond.
Yes, we do. There's been staff changes, and it's been a little bit difficult for them, I believe. And as soon as we have found the person now, and we're just trying to speak to them. So we will get there, and absolutely, we will bring you an update as soon as we possibly can.
Thank you very much. Councillor Drummond.
Yes, thank you. On the cervical screening, I mean, it's an all-time low. I find that really sad that it's really that low. But could you tell me what it's like in West Berkshire? So you've got any idea of the figures in West Berkshire?
I'm afraid I don't at the moment. This is a very new topic that's just come literally over the last week. We are looking into it. It's part of the health inequalities. It's very much part, as I say, part of the health inequalities that would need to be looked at. There is a very large cohort of ladies that are not accessing it, and that, you know, within the ethnic minorities, and we don't know why. And I think that's the issue, that there is a nationwide, the cohort is just not integrating or interacting at all, and there doesn't seem to be a reason why. So that's kind of the top layer of what needs to be looking at, and then there'll probably be a much deeper dive going in. But I know that this is something that has been discussed, possibly, you know, within Wokingham and Reading as well, and maternity overall is being looked at, but also just women's health in general. So it's kind of part and parcel of a bigger thing, I think. But this is the one topic that we want to kind of find out more, really. As I say, I'm sorry I don't have any stats available, but hopefully I will in a future update.
Thank you very much.
Thank you. Thank you for highlighting that, Councillor Drummond. Before I go to Councillor McCrae, I was just going to say, I assume that you are here in West Berkshire and elsewhere linking with groups that work with ethnic minority groups to sort of try and sort of, particularly on this issue, sort of address their anxieties or the reasons why they're not coming forward.
Yes, we will be. As I say, this is a very, very new topic. We are literally just starting at the very, very beginning to look, but we will be reaching out to as many different people as we possibly can to to try and find out what's happening. As I say, it's literally just come in, so it's all very at the very beginning stages of everything. So hopefully in the next future updates, we will have a lot more information for you.
Thank you very much. Is Councillor McCrow still there? Or has he gone?
Yes, I am.
You are. Hello. You've got a
Thank you.
question?
There's a couple of things really. First of all, phlebotomy, I'm very disappointed you've had so much difficulty there. I think it's quite an issue because last time I checked, I think there was you had to wait about up to 3 weeks to get an appointment. And, and that's the gateway. The first thing you do is get a blood test before you can get a diagnosis. So, there's a fair number of GP practices, I think, in West Berkshire do not have phlebotomists. Luckily, mine does, but so that's quite a problem, I think. But on the other thing is pharmacies. I would encourage you to try and look at that as soon as you possibly can, please. It's something that comes up over and over again, especially when we get these closures. And I think, half the
I think
was done. And and people say, well, I'm already having to wait an hour, and then the next pharmacy down the road is closing. How am I going to get anywhere? So I think there's something we do need to look at, please, because the rules kind of for pharmacy needs revolves around distance and time from the pharmacy. They don't kind of seem to rely on the number of people who are using a particular pharmacy. So please, if you can move that on quickly, please do.
We will try, of course. Again, I think a colleague earlier mentioned the hideous word of funding. We have been given money from Bob to do various things. However, as I say, that this is not currently on our work plan. There are just 2 of us at the moment, and it will be, I think, depending on how we approach it, quite a big project, and we would need to look at this to discover how the best way to approach it. And of course, if there is a deeper dive required, then it's going to need a lot more manpower, a lot more time put into it. Which, when we have lots of other things happening as well, it's a difficult situation. However, it's very much on our list to look at. So we will absolutely continue looking and monitoring and doing as much as we can with it.
Thank you.
Thank you very much for that. Councillor Foote.
Yeah, thanks very much, Martha. Fiona, you mentioned earlier, or Martha, I think, asked you about the champions and the fact that you said, you'd lost those. And I guess that's probably a funding issue. But it strikes me, if we're concerned about, an ethnic group that we're finding it hard to reach because of things like the cervical screening, that would be an ideal role for a champion from an ethnic group who understands the social cultural mores of that group, and to get the women to speak about why they're not coming forward for screening. Because the other thing that occurs to me is the vaccine, uptake of cervical cancer vaccine. Is that a feature where, for example, young women, students, at our schools from ethnic groups, are they encouraged or discouraged from taking that up? Because, we all know cervical cancer, it's a silent cancer, and before, it presents, it can be, pretty devastating and maybe too late disease to treat. So I think that is an absolute priority, really, to try and identify what exactly is going on here, and to try and take steps to rectify that, and apply for more funding, or try and ask us for to try and help you with funding in that regard. Thanks.
Yes, thank you very much. Thank you.
Right, thank you very, very much, Fiona. I think that's all the questions. Thank you for your presentation, and you can see that we're all very interested in your work. So
thank you.
Your projects. Thank you very much.
Thank you, Chair.
Bye-bye.
Thank you, everybody.
I'll turn it on again. We have item 12, which is page 45, which is just to about the task and finish group. This is our only task and finish group, and this is about the terms of reference. So assuming you've had a chance to look at them, and we are not quite all of us, but some of us are on there. The members on it are Councillor Culver, Councillor Jeffrey, Councillor Foote, Councillor Langford, and myself. So we're here. So this is important to us, and it is an important task group. Can we agree the terms of reference? Can I have a proposer? Councillor Jeffrey and a seconder. Oh, were you proposing? You're seconding. Oh, okay. Thank you. So that's Councillor Jeffrey is proposed and Councillor Langford is seconding. So thank you very much. So yes, we're looking for future dates for this group, which is really important, and it's broader, as the paper shows, than GP surgery. What? Oh, that's right. We were given one or the other, weren't we? That's right. I do remember. Thank you for that. Oh, we haven't voted. Right. Okay. All in favour? Thank you very much. Thanks, Nigel. Is the work programme. So obviously, we're always inviting proposals from councillors and members of the public for new items here. We've got quite a few that have been submitted, and we'll be looking at them. And there is a form on the website which allows people to nominate topics for health scrutiny. So hopefully the public will be looking at that as well. So there is a comment here. Members may wish to suggest additional mechanisms to encourage members of the public to put forward topic suggestions, e.g. promotion on social media, residents' newsletters, etc. Any thoughts about that? Do you think we should? So that sounds like a good idea, because it would be good to go out into the community, make sure they know about health scrutiny, and maybe sort of bring issues forward. I mean, maybe even Health Watch are still listening, might see from their contact with the public that there are issues that maybe we should be scrutinising. So we'd very much look forward to feedback from yourselves. Councillor Foote.
Yeah, thanks, Martha. Is that something that West Berkshire Comms can put out? We have the newsletter and things like that. Could it be a sort of like a standing item on that, or something on those lines? Thanks.
We did put something in the newsletter. I think a report back from our last meeting, I think. Is that going to be a regular thing?
Yes, absolutely. It can be topic based. So nearer the time of the next meeting, telling the public what will be on the agenda.
And inviting suggestions for topics.
Absolutely.
Very much so. So, that this is something that's live, and we're ever welcoming sort of suggestions coming in. Thank you. Right. Thank you very much. I think that's it. Well, thank you for your participation. We've gone much longer than we normally do, but we had a few glitches at the end. So thanks very much for participating. Good meeting. Thank you very much indeed. And I'll close the meeting. Thank you.